धन्यवाद sir. Are you ready?
ಗುರು
sir.
ಗುರು ಇವರು ಡಾಕ್ಟರ್ ಹರೀಶ್ ಇಲ್ಲ ಡಾಕ್ಟರ್ ಗಾಂಡಿಗೆ ಅನ್ಮ್ಯೂಟ್ ಮಾಡ್ತೀರಾ?
Yeah sir, I will same thing.
Do unmute him so that they can come up and welcome.
धन्यवाद sir.
Good evening, everyone. I welcome our host Dr. Gandev and Dr. Harish to this program and to start with the program.
Hello. Hello.
Hello. Shipata sir.
Network bandwidth is low ಅಂತ ಬರ್ತಾ ಇದೆ.
Namaste everyone. I'd like to introduce myself first. I'm Dr. Gandev Ramesh, Senior Resident Department of Anesthesiology and Clinical Care, Shema Maimila. Along with me, the host for today's evening master class, our ever
Sir, unmute yourself. Please use one single system, sir. System or mobile. Any one thing.
Can you hear me now? Hello?
Good to go. Good to go.
Good to go, yeah. Along with me, the host for today's evening masterclass is our ever dynamic and handsome Dr. Harish, who you guys will not be seeing live because some Chinese guy decided to eat a bear. Dr. Harish is an assistant professor in the Department of Anesthesiology and Critical Care, Shema, Mangalore. I myself had attended the PG Excel when I was an EGPG. I know the usefulness and quality teaching provided by some of the established gurus in our field who will be teaching you all. In the spirit of Atithi Deva Bhava, first I would like to welcome our first guest, Dr. Shalu IPE, Professor and HOD, Malankara Orthodox Syrian Church Medical College, Kolancherry, Ernakulam, Kerala, whose special interests are pediatric and obstetric anesthesia and palliative care. She is a certified instructor of BLS and ACLS and has authored textbook for bachelor's degree in anesthesia and critical care technology. She is also the convener Anesthesia Technology Training Committee. We are all fortunate to have her here and help us better understand CPR and also prepare you students for the upcoming exams, and which I'm sure you guys will no doubt do well. Accompanying Dr. Shalu as our faculty for for the master class is Dr. Shripad G. Mehendale, our own professor and HOD Department of Anesthesiology and Critical Care, Shema, Derelkate. It is my honor to be introducing him to you all. His special interests are pediatric anesthesia, regional anesthesia, difficult airway, bioethics, and medical ethics. I will run short of time enumerating his achievements and awards. To enumerate a few, I'd like to tell you he too is a certified instructor for ACLS and BLS and a faculty for AHA certified course in basic aid and resuscitation. He also has been the resource person in several different difficult airway workshops and also a wonderful quiz master for several anesthesiology quiz events at state and South Zone level. He firmly believes in the dictum knowledge is power and any amount of knowledge will not quench his thirst for acquiring more knowledge. He is a dynamic, ever energetic superhero HOD whose every heartbeat beats for the welfare of his students. Like I said earlier, no words will be sufficient to describe these two doyens of our field. On behalf of ISA Mangalore, ISA Karnataka, and the organizing committee, I heartily welcome both of you, sir and madam, to this prestigious event. Before we start this class, I would like to brief some basic rules about the conduct of the master class, which are 1. All audio will be kept silent while the faculty is speaking. 2. When the PG is asked question, that person should unmute and answer. 3. If another PG wants to answer or knows the answer, they will have to raise their hand. 4. Then the faculty or me as the host will ask them to answer. 5. Please watch out. We will watch out for the questions asked in the chat box by spectators and bring to the notice of the faculty if they miss it. And 6. If any PG is left out of the discussion, you can inform me or Harishana the same. Before all the best to all you students and have a wonderful experience. Remember, journey should be more beautiful than the destination. Cheers. Over to you, faculty, to start the class. Thank you.
Good evening again. Good evening, everyone. Again, I welcome our co-faculty, our main faculty, rather, Shalu Madam from MOSC Medical College, Kolancherry. She is an expert instructor, more than expert instructor, I can say, in CPR. She is doing this job for quite a number of years. So she is well versed with the oldest and most recent guidelines of CPR all over. And we don't have a better person than her to teach us about CPR. And also we have with us as a co-panelist our own Dr. Sandhya BS and Dr. Sushmita Patil, and also Dr. Megha A, Dr. Padma Rubini, Dr. Sneh Kaur, Dr. Swarna H, Dr. Jayant MS, and Dr. Ahalya. I asked them to come on and introduce themselves. Very brief introduction, then we'll start right away with the master class. Today's master is going to take us through BLS, ACLS, then dealing with the pregnant victim, pediatric CPR, recent advances, as well as Indian guidelines. And again, I thank our hosts for a wonderful introduction. Whether it is true in my case, I don't know, but definitely they did some justice to madam's introduction. Thank you very much. Can the other PG participants can introduce themselves quickly? Are they unmuted, Guru? Dr. Megha, are you there? Dr. Ahalya? I think they have some issues with connectivity. Till then, we'll run a video of BLS. I am sharing my screen and we'll start right away. Here is a video of demonstration of BLS, beautifully rendered by our residents, Dr. Apurva, Dr. Sushmita, Dr. Sandhya, Dr. Prarthana et al. This is the video for you.
No sound.
10 seconds.
Are
There
you
is
able
no
to hear the
pulse,
sound
no
now?
breathing.
I'll start from the beginning.
Activating emergency response in the car parking of Shema.
Are you able
A
to hear?
rescuer has noticed this.
Yes.
Rescuer arrives. Ensuring scene safety. The scene is safe. Hey, are you okay? Are you okay? Checking for response. Help. Calling for help. Checking pulse and breathing simultaneously in less than 10 seconds. There is no pulse, no breathing. Activating emergency response and asking for an AED. Beginning chest compressions. CPR is activated. Hand is placed in the lower half of the sternum. Push hard, push fast. Compression rate is at 100 to 120 per minute. At least 5 centimeters. Allowing complete chest recoil between compressions. Minimizing the interruptions. The second rescuer has arrived with the AED. Turn on the AED. Place the paddles. The first paddle is placed below the right paddle. The second paddle is placed below the left nipple. Continuing chest compressions at rate 100 to 120 per minute. Stop compressions for analysis of rhythm. Do not touch the patient while analyzing the rhythm.
Do not touch the patient analyzing heart rhythm. Shock advised.
Shock is advised. Continue chest compressions.
Everyone clear.
Charging. Charged. Clear.
Clear.
Shock delivered. Shock delivered.
Delivered.
The second rescuer gives chest compression at a rate of 100 to 120 per minute. At least 5 centimeters. Push hard and fast with minimal interruptions. At 30 compressions, 2 rescue breaths are provided. avoid excessive ventilation. Continue chest compressions.
10, 20, give 2 breaths.
2 breaths at the end of 30 compressions and resuming compressions immediately. Switching over every 2 minutes.
20,
2 minutes or 5 cycles.
30, give 2 breaths.
Ensuring minimal interruptions.
10,
Sorry for that audio problem. Thanks, Dr. Sandhya, Dr. Sushmita, Dr. Apurva, and Dr. Prathana. Now over to Shalu, madam. You may please start.
First of all, let me thank you for inviting me as a faculty to a wonderful conference. The BLS rendering was just beautiful. The audio was just superb. Want to congratulate your team for making it possible. So warm good evening to all of you. We have a huge amount of portions to cover. Now, how fast we can move and how effectively we can move depends on how our panel members are going to help us out. Now, we start with the first question. When was the latest AHA guidelines published? The date of latest AHA guidelines. Can you hear the question, and is somebody going to take the question? Is the slides seen? Dr. Sripada, can you unmute?
Yes, madam, we can see the slides. Nicely seen.
Okay.
Beautiful.
Now the first question is, when was the latest AHA guidelines on CPR published?
Anyone can answer, please. If they don't answer, we'll go ahead, madam.
Okay. So the latest AHA guideline.
Chat box.
It becomes difficult to know. Anyway, we'll see. Okay, all right. We'll open the chat box and see how it's going.
It was, we have to move fast because the topic is fast. So it was the latest guideline, AHA guidelines were published in CPR were published in 2020. And what is adult chain of survival according to 2020 guidelines? What is adult chain of survival according to 2020 guidelines? Is somebody going to answer, or
Recovery has been added, ma'am, as a 6th chain to the existing 5-chain protocol.
Okay. And how, what is the difference between IHCA and OHCA?
In hospital and out hospital.
Okay. And the 6th chain has been added. And which is the 6th chain which is added?
Recovery.
Okay, recovery, because they thought it is important to have a chain on recovery because it's important to get the patient back to the original shape. Now we have a case scenario. See, this is the 6th chain which is added. Now we have a case scenario coming up. 35-year-old male who's a chronic smoker presents to emergency room with a history of chest pain and breathing difficulty for 30 minutes. Patient is unresponsive. How do you proceed? What are the steps of resuscitation that you're going to take up? How are you going to start the resuscitation process? What are the steps of resuscitation process? When you meet an unresponsive patient in the ER, what are the steps you are going to undertake?
Dr. Akash has already put in detail the steps involved, madam. He has put scene safety, call for help, assess the patient, alert EMS, start CPR, get an AED, then after everything, hospital follow-up.
How long Dr. Sripata said you have to look for a pulse. Which is the pulse you're going to look at in the adult and why?
Carotid.
Carotid pulse.
Why carotid? Why carotid?
Yeah, less than 10 seconds, that is right. Madam is asking why carotid. Is it just close to heart? Central pulse. Yes, Shilpa. I think you can unmute and answer as well.
It is a central pulse and it is the first to come back and the last to go. So you want to be sure of that. That is, and you palpate for 5 seconds, at least 5 seconds, not more than 10 seconds. And simultaneously you look for breathing. What is high quality CPR that we keep talking about? What is high quality CPR?
Ensuring chest compressions of minimum 100 to 120 with the chest compression depth being up to 5 centimeters. Okay, and allowing the good chest recoil in between the compression so that it will refill back with the returning blood.
Compression ventilation ratio?
It is your two.
Compression ventilation ratio?
30:2 in adults.
In adults, okay. When you and it should be uninterrupted, okay, because then you can do a so this is what we were talking about. Very well done. Then the defibrillator arrives. You have called for help and the defibrillator arrives. What are you going to do next?
Turn on the defib and put on the
defib and what do you want
pads,
to do?
and then we'll stop CPR and let the AED analyze the rhythm.
Analyze the rhythm. What do you want to find out from the rhythm?
We are looking
shockable or non-shockable.
It is shockable or non-shockable.
Madam, can they tell us what is AED and what is special about AED?
What is AED?
Automated electronic defibrillator.
Okay.
Automated external defibrillator.
External defibrillator. What do you mean by automated?
How is it
analyzes automatically? It analyzes.
Yes.
Yes.
Rhythm by itself, whether it is shockable or not. We need not. I mean, any layman who does not know interpretation of the ECG, by analyzing itself, whether it's shockable.
If it is shockable, what does it do? the AED will shock.
Then we'll have to make sure.
Then it will charge and then it will say that it's ready to give shock, and then we have to clear and deliver the shock.
Okay. So in the ER, what will be the defibrillator you are using? Emergency room?
Depends, ma'am, both AED or.
That also has AED mode actually. We can change it to the AED mode and use it.
Okay, you can either use the regular one or you can change to AED mode. Now, which are the shockable and non-shockable rhythms?
TVF, shockable.
Non-shockable are asystole and PEA, pulseless electrical activity.
And shockable?
Pulseless VT and VF.
Okay, that is good. Now I'm going to show you some ECG rhythms in cardiac arrest. You can quickly identify them. What is this?
VT.
VT. Monomorphic VT.
It is white, complex, irregular. What is it?
Ventricular fibrillation, ma'am.
It is a ventricular fibrillation that you're seeing. Now, next one. What is this? The patient has no pulse. I'm telling you, the patient has no pulse.
Monomorphic VT.
Monomorphic.
Monomorphic VT.
Pulseless.
Answer is not complete.
This is a cardiac arrest rhythm. So, what is this?
Pulseless VT, shockable rhythm.
Okay, pulseless VT, very good.
Shockable rhythm.
Now, what is this? No pulse again. No pulse felt. What is this?
Pulseless electrical activity.
Okay, if there is a pulse, then it is different. So, in the cardiac arrest, it is pulseless electrical activity. And what is this that you're seeing?
It's a flat line. We need to recheck if it's a flat line protocol we need to follow.
Okay, what is the flat line protocol you're going to follow?
We will check the leads if they're connected or not. If they are, and if it's flat line, we should continue CPR.
We need to check the amplitude.
Should be connected.
You have to tell three things together when you say flatline protocol. Please, all of you, when you answer, please unmute and put on your video so that we can also see and know who is answering. Everybody else can appreciate that. Those who are answering. Okay. Thank you.
Okay, so quickly tell us how you make know it is how you do the flatline protocol.
We need to make sure that all the leads are connected to the patient and back to the AED or the monitor.
Good.
Okay.
And we need to check for the amplitude in case if we have to increase it.
Good. One more thing.
You have to do the gain on the monitor. Okay. So that
Then
is
you have to change the lead as well. Lead 1, 2, 3, whatever
1,
lead.
2, 3.
Okay, right.
Okay. So what you're seeing is an asystole. Okay, this is our patient again. We have come back to our old patient who is in the ER, who is unresponsive. And how are you going to manage him? How are you going to manage the unresponsive patient? This is the unresponsive patient you're going to manage in the ER. You're called in. How are you going to go about managing the patient? Somebody can start and somebody else can help.
Guru, can you please unmute Dr. Akash?
How do you start? You see an unresponsive patient. How do you start?
Hello. Yeah. So actually, first I will start with BCLS protocol. First, I'll assess scene safety, and then I'll ask someone for help and try to call out the patient. And then I'll also feel for the pulse, and then ask the whoever is there, like the doctor or the nurse, to immediately activate the emergency services. Usually, if it's in the hospital, we can tell them to activate code blue. And in the meantime, I will assess the pulse and also look for chest rise and breathing. If it's absent, then I would start giving CPR. Hopefully, in the meantime, the
Okay,
code blue team would have arrived.
Okay, the defibrillator has arrived.
Yeah, so I will connect the pads, and I will stop CPR and analyze the rhythm.
It is VF.
If it's a chargeable, if it's a shockable rhythm.
It is VF. I am telling you, it's VF.
Ma'am. Then while the AED will be charging, I will continue CPR. Then the AED will beep and tell me that it's charged. That time I will give compressions. I'll be giving compressions at the that time I'll give shock once it's charged up. Once everyone is clear, and then again I will continue doing CPR. Hopefully, in the meantime, the code blue and other team would arrive, ma'am. And that time I can assign everyone roles, like someone can take over compressions, someone can take care of the airway, someone can take care of the defibrillator, someone can connect IV line, someone can document what is required, and send investigations like as per what is required. And the CPR will continue in the same way. If required, we will secure the airway, and we have to keep reassessing every 2 minutes. And in the meantime, every 2 minutes, we'll give adrenaline and other drugs as per whatever the rhythm is coming in the AED.
It is VF, persistent VF.
Amen. Then we will give shock at rate of around 100 joules. And we will continue with CPR, and we will be giving
shock.
Sorry, ma'am.
Defibrillation. What is the shock you use? What is the joules you use?
100 kilojoules, ma'am, for VF.
Defibrillation you always use high joules.
360, 360. Sorry, ma'am.
And that is if it's monophasic.
Monophasic. If it is biphasic, then 200.
Okay, so it is high joules that you always use, and then
we will again we will continue CPR, ma'am.
Why do we after every shock? Why do you continue CPR? Why can't you look at the pulse and decide whether it's already there or not? Why do you have to do CPR after defibrillation?
We want to continue the chest compression so that the cardiac output is maintained to the vital organs, ma'am.
Okay, so you don't expect to get a good rhythm immediately after shock. You have to pump in blood before you get a rhythm. Okay, then.
And again, suppose 2 cycles are over, then third cycle if you are going for, then we should give adrenaline also to the patient.
How much?
1:10,000, 1 mg, ma'am.
Okay, good.
And then again, we will reassess, ma'am, after 2 minutes, and this cycle will continue until we will achieve ROSC.
And
usually by then.
What is the next after adrenaline? What is the first adrenaline? What is the next drug you give?
We can give amiodarone, ma'am.
Okay, what is the as an alternative to amiodarone? What is given now, according to new guidelines?
Not sure, I think mag sulfate.
As alternative, not that amiodarone is taken off. There's something else which has come, that is lignocaine. Also, you can give. Okay.
Lignocaine also we can give 1 to 1.5 per kg.
And what is the next dose? The next drug that you give after amiodarone?
Again, we will give adrenaline, ma'am, next cycle.
Okay, very good. Do you think of putting in a definitive airway sometime along the line?
Yes, ma'am. In between, if like whoever is taking care of airway, we can ask them to secure the airway as well with the ET tube and monitor with end-tidal carbon dioxide.
Okay, that will
To
tell
check
you
the
position and
quality of-
also that it is in place.
Yes, ma'am.
Okay, that is good. Now, if it is a non-shockable rhythm, how do you proceed?
Then, ma'am, we won't be like giving shocks. We will just be giving CPR to the patient.
Okay,
And
very good.
we will not give amiodarone. We will just give adrenaline, ma'am, every other cycle.
Okay, well done. And do you think of the causes along these lines? Why it happened?
Yes, ma'am. In between, we should discuss like what are the possibilities that may be causing these, and we can also send investigations out. 5H and
Okay,
5T.
when you're taking blood, you can send investigations. And what are the things you think of?
Like hypovolemia, hyperkalemia, hypokalemia, then tamponade, things like this, ma'am. 5H and 5Ts.
Okay, I think you have done a good job. And the things which is, can you tell me the things which is new into 2020 guidelines compared to the other one, compared to 2015?
I mean, 2020, I think they have included pregnancy in the CPR guidelines, and also that recovery
Not
period in hospital in the ACLS guidelines. I'm not sure, ma'am. 2020.
So the things which has happened is they have confirmed, reaffirmed the importance of good CPR. Then the epinephrine early in the cycle in asystole, in non-shockable rhythms, and lignocaine has been added. And also they have added audiovisual and physiological audiovisual aids to know your quality of compression. Okay, can somebody tell me what the audiovisual aids which are added for good CPR quality? If you are tired, somebody else can take over. But you have done a good job so far.
Thank you, ma'am.
What are the audiovisual aids, feedback devices that is there for you in the new this thing for you to know the quality of your CPR?
One is end-tidal carbon dioxide, ma'am. We can check. Another
That
is there's
is
a small box which we can keep while which actually checks the quality of the CPR while performing.
Okay. When you have carbon EtCO2, what is the target that you're thinking of?
Target should be around 30, ma'am. If
At
30 is
least,
reached, then ROSC is reached.
Okay. So for
At
you
least
to say
15.
For you to say it is good CPR, good compressions, you have to have at least 10 EtCO2. Ideal is 20. But if it is less than 10, then you have to improve your quality of compression. So that means you have to have an ETTN. And what about arterial blood pressure monitoring?
If available, ma'am, we should start securing and monitor it as well. Be useful guide.
If available, okay. And what are you particularly looking at? You're particularly looking at the diastolic BP. Okay. And this is the instrument which you're going to keep on the chest when you're doing compression, so that you know the depth and recoil and other things, but mainly depth and recoil. Okay, now we move to the next scenario. Patient after obtaining ROSC is unconscious, has a systolic BP of 70 millimeters of mercury, pulse rate of 90 per minute. How are you going to manage? So the patient, how do you know the patient has attained ROSC?
If EtCO2 is 30, then we can.
Okay, what else? What else? Suddenly, what will come? What will you be so happy about?
Pulse.
Yes, pulse, and with the pulse, BP. Okay, fine. And then what else? EtCO2 will rise. and what there will be spontaneous tracing on the arterial tracing if you have already have an arterial line in. Okay, all that you've seen and you're very happy, and the patient is up, but the patient is unconscious. Systolic BP is only 70 millimeters, pulse rate is 90, and how are you going to manage this patient further on? Because your aim is to get this patient back discharged as he came in. How do you proceed?
Because BP is on the lower side, ma'am, we will
Yes.
first try to give some fluids and probably try to start inotropes.
Can you tell me in a structured manner, A, B, C? You can start with A, B, C. I know you know everything, but can you put it more in a structured form?
Like we should again reassess the patient.
Yes, very good.
In a ABCD format. Again, see airway, if probably by then airway is already secured.
Yes, very good.
Then we should see the breathing, and we should auscultate the chest again to see if there's any added sounds or any
Okay,
abnormalities.
fine. Your ETCO2 is showing good tracing. Okay, then.
And then after that, for the circulation, we should check the pulse.
No,
and see the BP.
Let's finish one and then go to the next. So your airway.
Once again, my battery is running out, ma'am. I'll just go and connect the charger once again. Can someone?
Okay, can someone take over while he charges? He's got the endotracheal tube in, and he wants to manage air. So airway is managed. He wants to manage ventilation. Can somebody help? Yes, can somebody help? Can somebody take over? How do you manage breathing?
The targeted saturation should be 92 to 98%.
Very good.
And ETCO2 should be adequate. And the ventilation should be at least 10 to 12 per minute.
Okay, 10 breaths per minute. Let's say easy, 10 breaths per minute, and your targeted targeted carbon dioxide is 35 to 45. Then, and you should do saturation. You said okay. Then now we move on to circulation. C.
Yes, circulation minimum arterial pressure should be more
So
than.
what do you have? You have all the monitors in, and if possible, you have a ECG. Okay, 12 lead ECG. Okay, then.
Yeah, the minimum arterial pressure should be more than 65 millimeters of mercury.
That is mean arterial pressure.
Yes, mean arterial pressure.
And the systolic?
Systolic should be more than 90.
Okay, very good. Okay, then?
Then should assess the consciousness of the patient.
Okay, very good.
And if in this patient,
so that this patient is unconscious.
Yes, yes, ma'am. We need to initiate the target temperature monitoring, ma'am.
Okay. Now, is there any? Are there things in the cardiovascular system which we could correct and which needs immediate attention, which you should be troubleshooting for?
Is there any ACS acute coronary syndrome is going on? We should address that.
Is there a possibility of this patient going to the cardiac cath lab?
Yes, ma'am. If there is any,
in case.
In that case,
in 12 ECG, we need to assess the cause for the arrest. If it is like STEMI causing it, if it is any cardiac cause, we need to refer the patient for the cardiologist and critical care for further management. And in 12 ECG, we'll get to know about it. And if anything else is required regarding if the patient is awake or not, we need to look for the consciousness. After assessing for the consciousness, if patient is awake, then
he's unconscious.
if the patient is unconscious, then yeah, if he's unconscious, then we'll have to go for this TTM, ma'am, and we have to look for the we have to obtain CT and EEG.
TTM? What is TTM?
Temperature. Targeted temp.
Correct.
I'm not able to remember it. Targeted temperature
management.
Management. Yeah. Targeted temperature management.
Okay. How do you do target? You have any idea how we do targeted?
Find out for the cost.
How do you do targeted temperature management?
By by cooling down the body by giving rapid cool saline, and also by mainly by giving cool saline, ma'am. Cool blankets.
And cold blanket. And what is the and you should always monitor the core temperature. And what do you want the temperature at?
Around 32, ma'am. 32 to 36.
Okay, very good. And how long do you cool and how long do you warm?
Hello, ma'am.
How long do you cool the patient?
36 degrees Celsius over 24 hours, ma'am. That's the cooling time.
And then you rewarm the patient for and taking
warm back for every few hours.
And then
the
taking
rewarming time will be again slowly for next 24 to 48 hours.
Next 24 hours usually. Okay. Now that is very good. Now,
and we need to start ETM at the earliest without delaying in case the patient is unconscious.
Okay, that is very good. So it takes priority. So that is the post-cardiac arrest algorithm that we have here. And once this is over, then there is a new thing in the new guidelines, that is multimodal neuroprognostication. I can put put the slide up for you. Can somebody tell me what this is? Can somebody quickly tell me what this is? This is the new edition in 2020. I can see Dr. Ravali.
Neuroprognostication. Neuroprognostication, ma'am, will after if the patient is unconscious, we will be cooling him, and following for the 24 hours, we'll do the cooling and head CT will be done. In the next, after 24 hours till 78 hours, we'll be rewarming the patient and limit sedation, and we'll be monitoring with the MRI, and neuron specific enolase will be checked, ma'am, and his EEG will be checked for burst suppression, ma'am, for knowing the prognosis, neurological prognosis, if any ischemia has happened, brain neural ischemia.
Now, how long do you wait for to incorporate multimodal prognostication diagnostic tests?
For after 24 hours, we'll do, ma'am.
After 72 hours. Okay. Now, is when you do the all the other tests you will do, but multimodal prognostic tests you will wait till then.
Okay.
Okay. Now we have so you all have done a wonderful job. Now we move on to the next clinical scenario. This is a 32-year-old primate at 34 weeks of gestation brought to the labor room following an episode of convulsions. So it's 34 weeks in convulsion. On arrival, patient was stuporous with a feeble pulse and low BP. Patient is unresponsive with an absent pulse. Soon he became unresponsive with an absent pulse. How will you proceed? Who's going to tell me about the pregnant patient? You all have done wonderfully well so far. Can somebody take up the pregnant patient who is unresponsive? Yes. Who's taking up? Somebody has to start and then we will help you out.
We'll assess the patient, ma'am, and we'll support the patient with 100% oxygen and.
This patient is unresponsive with an absent pulse. So what do you have?
So we'll do left uterine displacement and we'll start CPR, ma'am.
Okay, you'll start CPR, and how are you going to progress?
We'll start chest compressions and we'll give 100%. We'll be managing the airway with advanced airway.
Okay, very good.
CPR, and we'll be checking the rhythm. If it is a shockable rhythm, we'll be giving the shock. And if the ROIC is not attained within 5 minutes, we'll perform a perimortem cesarean delivery.
What about IV? Where are you going to put the IV?
Above the diaphragm.
Okay, you have very clever, smartly told me that you will continue uterine displacement, which is very important in this patient because of, for what reason. And what about the airway in these patients? Are you going to find it difficult to do it, or?
Yeah, ma'am, it is difficult airway. So.
And why do they? Why is it that they go into hypoxia easily, these patients?
Airway edema during pregnancy.
And what happens to their FRC and things like
that? FRC.
Okay.
Yeah.
And why do you want to do perimortem cesarean at within 5 minutes? What is your idea of doing the perimortem cesarean?
Because the neonatal oxygenation will be compromised. So within 5 minutes, we have to deliver the baby to revive.
It will improve the mother's CPR resuscitation efforts also.
Oh, very good. That is the first thing which you have in mind. The baby, if you are not getting ROSC, that means your mother is going to go. So for that also to improve, both is important. And who will you keep ready when the baby is born?
Neonatal
okay.
Resuscitation team.
Resuscitation team. Okay. Now this is the protocol. Now can you tell me the etiological factors which could lead to cardiac arrest in pregnancy? You have a mnemonic ABCD up to H. Can you name them?
Bleeding, pre-existing cardiovascular disease, drugs like Magself, embolism, any sepsis related concerns.
Then
fever.
General non-obstetric causes, ma'am. The 5 H's and T's.
5 T's and preeclampsia, hypertension.
Okay, very good. So then we go to the next case scenario. 60-year-old man sitting in front of cardiology for OP for consultation feels giddy and is laid down. His pulse rate is 40 per minute and is low volume. How do you manage? What is it that how are you going to manage this patient? He was sitting, waiting in front of cardiology OP to see the cardiology consultant, and he was feeling giddy and was laid down because he collapsed. His pulse rate is 40 and his volume, low volume pulse. How do you manage? What do you think has happened to him? Yes, we can start and then we can pitch in.
This is bradycardia with pulse, ma'am. So we follow the bradycardia with pulse algorithm.
Very good. Okay, how do you go about it?
This patient has symptomatic bradycardia. Hence, we give atropine IV at the dose of 0.6 mg every 3 to 5 hours. Every 3 to 5 minutes. And if that is not effective and the heart rate has not come up and the symptomatically the patient is not better, then the patient.
I want to make one correction that in the 2020 guidelines, atropine dose is escalated to 1 milligram IV 3 times. That will make it maximum 3 milligrams. Is that okay? Okay. So 1 milligram atropine 3 times, which is maximum of 3 doses. That will make it 3 milligrams. Okay. Then still not corrected. What are your other options? You're given atropine. What are your other options?
And dopamine can be started now.
Okay, dose?
Dose is 10 to 20 microgram per kilogram per minute.
5 to 20 microgram per kilogram is the new guidelines. Okay, then epinephrine also you have tried. Then it is not getting under control. What is your next option?
Pacing.
Okay, percutaneous. Okay. Now, how do you know this patient needs treatment and is symptomatic?
Ma'am, the bradycardia.
Hypotension.
Okay, there is again
angina.
Okay.
The patient can be classified.
Okay, hypotension. Then
Any signs of shock, angina.
Now there is again one mnemonic to remember that is CHAPS. C is for cardiac failure, acute cardiac failure, acute. H for hypotension. A for acutely altered mental status. P for pain chest, and S for shock. So this is a mnemonic you can remember, CHAPS. So you have successfully treated the bradycardia, and I have some cardiac rhythms for you. You can identify them. First one.
Sinus brady.
Sinus brady.
Okay, that is sinus bradycardia. Then number 2. Number 2. Doesn't matter if it is wrong.
Somebody saying complete heart block. That's right.
This is morbid type.
Type 2. Yeah.
Okay. What happens in morbid type 2?
Sudden missing of
average drop and PR interval will be same, constant.
Some now you have the third one. What is the third one?
Type 1.
Third one.
First degree heart block.
First degree heart block. Okay. Fourth one.
Ringerbeck's phenomenon.
Pardon?
Prolongation of the PR interval and a missed beat. Morbid type 1.
This is
complete
complete heart
heart block.
block. Okay. Now what is fifth one? Fifth one. Only one left. Okay, this is morbid type 1. Okay, now we Now we move on to the next case scenario. A COPD patient admitted for respiratory complaints of palpitation, respiratory infection, complaints of palpitation, breathlessness and dizziness. Pulse is rapid, thready and irregularly irregular, and BP is 70/40. ECG showed is atrial fibrillation. How do you manage? So this is COPD patient with respiratory infection. He is complaining of palpitation and breathlessness. But you have a rapid thready pulse and irregularly irregular. So if it is irregularly irregular, it is likely to be atrial fibrillation. BP is only 70/40. How are you going to manage? Okay, Deepika, come on.
Good evening, ma'am. Since the patient has hemodynamic instability with atrial fibrillation, I would like to directly go for cardioversion, ma'am, synchronized cardioversion.
Okay, good. And before synchronized cardioversion, there are things which you should do, no? Before you start synchronized cardioversion.
Ma'am,
You have to get the things ready and all for this, no? Meanwhile, what all will you look at?
Ma'am, I'll connect monitors to the patient. I'll assess the consciousness of the patient.
Again, ABC.
Yes, ma'am. I'll look for the airway of the patient. If the patient is unconscious, I would like to secure his airway and see for the breathing pattern and secure a IV cannula for to administer emergency drugs. And then
the data.
Okay, because you're running out of time, you decided on cardioversion. Now, how do you do a cardioversion? Just tell me the steps of cardioversion.
Sushmita raised hand.
And ideally, we'll have to take consent of the patient, then we prepare the crash cart ready, and sedation also has to be administered. Since it is irregular complex, I would like to go ahead with, hello?
Yes.
I would like to go ahead with cardioversion after securing the, like, we have to see the patency of ABC has to be followed, consent taken, crash cart kept ready, sedation also advised, and cardioversion of 120 to 200 joules. I would like to go ahead with, ma'am, cardioversion.
Okay, and can you tell me the steps of cardioversion?
Ma'am, in this one, we have to attach the paddles, ma'am. But here the most important point is to press the sync button in the cardioversion. After charging, like we have to take the paddles, charge up to 120 to 200 joules, then synchronize, and then the shock is delivered after the clear is announced.
Okay. Now
this is after consent and sedation, ma'am.
Sedation, depending on this patient, you can probably give sedation because he's got 70 BP at least. Okay, yes. Now I'll show you some tachycardia rhythms. You can identify and tell me also how much joules you will use for the particular thing to cardiovert. First one, please.
Yes, VT, ma'am.
Now, how much?
50 to 100 joules.
Yes, first one no sinus tachycardia. So you're not going to cardiovert it, no?
No.
And what was the second one? What is the second one?
It's atrial flutter, ma'am. It's atrial flutter.
Is it atrial flutter? It is irregularly irregular. And what you're seeing is the fibrillatory waves. So what is it?
Atrial fibrillation.
When you see something irregularly irregular, it is most likely to be atrial fibrillation. And what is the joules you will use for this patient for cardiovert if it is an acute case?
150 joules, ma'am.
120 to 200 joules, ma'am.
Okay, the maximum joules you will use is atrial fibrillation. Okay. Now we move on to the third one. What is that? Yes, correct.
Homomorphic weight.
And how much joules do you want to, and if you want to do cardioversion?
100 joules, ma'am.
100 joules.
Okay, that is the middle one. Now we move on to the fourth one.
This is SVT.
And how much joules?
50 joules.
50 to 50. We'll start with 50, man. 50 to 100.
Okay, so that is the one which requires the least of the joules, least amount of joules. Okay. Now the next one.
It's atrial flutter, ma'am.
Atrial flutter. Okay. Again, the only 50 to 100 joules for this also, the lowest. And what is it that you're seeing and on 6?
It's torsilis depointis.
Torsilis depointis.
Polymorphic.
Polymorphic, very dangerous condition. You can anytime go into ventricular fibrillation. And how do you what do you do with this rhythm?
Defibrillation.
You should defibrillate.
Defibrillate.
Okay. Now, is there time for mega code? Because we started little late. Dr. Sripa.
We'll see in the end, no, madam.
Okay. Because we started little late.
Most of the things we discussed. So we'll see in the end, no? If you don't mind.
Okay. Because we started little late.
Yes, ma'am.
Okay. So the children have done wonderfully well.
Yeah, very good.
Very happy with them.
Yes.
Congratulations.
Thank you.
Now we'll move on to, thank you, man. Thanks very much. We'll go back to mega code in the end. If we can do it.
Okay, if time
permits, yes. Because 7:30 we have to hand over to next team. Very interesting discussions there.
We started little late.
Yes, madam. Sorry for that.
We started little late also.
Yes, yes. So we'll go on to next. This is go to pediatric. We dealt with adult CPR so far. So now we'll go on to pediatric. So can anybody tell me who are the pediatric victims? Quickly, somebody. Nobody is answering. Right. Pediatric victims can be infant and a child. Infants are those who are less than 1 year. But for neonates, we have different algorithms. So we more than 4 weeks to 1 year, they're infants, and more than 1 year to puberty are called children. So how do I identify your children? By looking at the chest hair or axillary hair or presence of breast buds. You can please raise hands and then we will proceed asking questions. So can anybody tell me what is the depth and rate of compression in case of pediatric victims? Is it different from adult or is same? Nobody is there. Okay, Shilpa. Dr. Shilpa.
For infants, no. For infants, it's 4 centimeters.
Hello, sir.
Yes, please.
Sir, the rate is 20 breaths per minute for infants, sir.
Rate and depth of compression we are discussing. What is the rate of compression? Okay.
20 breaths per minute?
No, we are talking about chest compressions, right? So chest compression.
Sorry, sir, 30 per minute.
100 to 120 per minute, just like any other victim, it remains same. Whereas depth varies depending on the size of the child. Yeah, there is a lot of answer in the chat box. It is very standard to have 1/3 of anterior posterior diameter of the chest. That much depression should be there. Somebody is raising hand. Come, yeah, please. Who raised the hand? Okay, so for the children, it is about 5 centimeters, whereas it is more than 5 centimeters, 5 to 6 centimeters for adults, whereas for children it is about 5 centimeters, and infant is about 4 centimeters.
4 centimeters.
Okay, right. So there is a rate, and rate remains same for all ages, whereas depth may remain, depth changes depending on the size of the victim. What is the level of, where should you compress? In the adult, you compress lower third of the sternum, whereas in adult, in a child, where you compress? In an infant, you should compress below the level of nipple, right? Right. So then, what is the technique of compression?
If it's single rescue, we can use index and middle finger to compress.
Again, you should be specific about whether you are doing it on a child or in an infant, right? There's a
in
difference.
an infant,
Yes.
In an infant, we should do it using 2 fingers, index and middle finger at the level of nipples. But if you're double rescuer, then one will take care of the airway and other one will grasp the baby with both hands and compress with thumb.
That's called two-thumb encirclage technique. Why two-thumb encirclage technique is preferred over two-finger technique?
Better quality of compression.
Better quality of compression.
Sir,
So
counter pressure can be given with the hand that is under the chest, sir.
So you can stabilize the patient. You can, yeah. So all
Counter
these
pressure.
reasons, not exactly counter pressure. You have better efficiency with the two-thumb technique. So you get better compressions. Right. That is encircling the chest of the child is to stabilize. Right. Whereas in child, you can use a single hand or both hands depending on the size of the child, but you should make sure that you should only use the heel of the hand, right? What is a compression to ventilation ratio?
30:2, sir. In children, in infants, if it's single rescue, 30:2. If it's 2 rescues, then 15:2.
So all patients, when a single rescuer is there, it remains. Yeah, Sushmita. Yes, Sushmita.
Hello, sir.
Yes.
Sir, it is 30:2 in adults, children, and infants, sir. But if it is double rescue, then it becomes 15:2, sir. But the compression rate is 100 to 120 beats per minute.
Yeah, but the newer guidelines have any difference?
Two single rescue for all age groups, sir.
Yes.
And 15:2 in 2 rescuer for children and infants.
Infants. Right. Then it is because of oxygen requirement in children is one reason. More than that, many times the cardiac arrest can be because of hypoxia in children. So we have to give more attention to oxygenation. How to assess the responsiveness?
So a tap on the feet or a flick on the feet can be there for the infants or children.
Yes. Yes. Right. Or you can squeeze the shoulders of the child. Okay. Well, how do you recognize, feel the pulse?
Brachial pulse.
Brachial pulse in
Infants, sir.
infants. Why brachial pulse?
Inner portion of the upper arm.
Why? Why not carotid pulse? Because in children, they have a short neck, they may be chubby, so it is difficult to have recognize in infants. So we look for the brachial pulse in the middle of the inside of the arm. Right. But in children, you can either go for carotid pulse. If not able to feel, you can go for femoral pulse. How do you use defibrillator?
So the pads are attached, one in the front and one in the back, sir. The hello.
Yes, yes, please. Okay.
So the padding attachment is different in the pediatric age group. The one pad is attached on front of the chest and the other on the back of the chest, sir.
Okay, either you can choose to have pediatric pads. If they are not available, you can use adult pads. You can use either, preferably use the AED with the pediatric attenuator. If not available, you can use adult attenuator, right? Sorry, adult AED as it is. What should be the energy setting? If nothing is available, always prefer to use manual defibrillator because you can give the energy according to the size of the child. If you give too much, it is dangerous. So it is always better to in hospital arrest you use the manual defibrillator. What should be the energy setting?
4 joules per kg, sir.
4 joules per kg. Yes, you can start with the 2 joules if not successful 4 joules, but it should not exceed 10 joules per kg. Right. Right. Then how to manage choking?
If they are responsive, we should take the baby and flip it over on the knee and gently hit it with the heel of the hand.
It depends on the what is the condition of the
responsive
patient.
Or not.
Okay, yeah. So whether the patient is adult or infant, and second point is whether responsive or not, complete or incomplete. 3 points. If this incomplete choking, then we can take him to the specialist if you are not able to retrieve it. So patient can wait with oxygenate, monitor, and get a ENT or whatever surgeon's consultation. With the complete choking, it's an emergency. Immediately you have to respond. So you recognize whether this patient is responsive or not. How do you recognize choking in a responsive victim?
They will be having signs like they will
universal
hold
choking sign first. No, they hold the neck. Then other signs like grimace and cyanosis. Right. How do you manage in adult responsive victim?
We can give Heimlich maneuver, sir. We will stand behind the patient and push just below the diaphragm with a fist and the other hand supporting it in upward direction.
Yes. So upper abdomen, you make a fist and support the patient from the back. Keep your legs in between so that if in case he collapses, you support and give rapid upward thrust. What is the mechanism?
We are increasing the pressure by pushing up the diaphragm, which will try to expel the
you increase intrathoracic pressure so that it produces sort of artificial cough. Right. Right. In children, what you do? Is it same or different?
We should turn the child over on a knee, and if responsive, we should.
If responsive child is there, you do same thing, but you may have to kneel down and go behind the child and do it. If it is an infant, there is a difference. In a responsive infant, as I said, we give back slaps and chest compressions.
Chest compressions.
Okay, as I said, you have to support the child on the arm, supported by thigh. Keep the head below the body. Keep the child prone. Open the mouth and give quick back slaps. 5 back slaps. Turn over the child. Always support the head. And now give chest compressions. How are you going to give compressions? Is it same as CPR or different? It is technique is same, but you are giving 1 compression per second. Right. Technique is same, 2 finger technique. And how you manage an unresponsive victim of choking?
We should again start the CPR protocol, which we usually do, like if any patient is unresponsive.
Yes, very good. What is the difference?
Before giving
while
breath, we
we are
examine
giving the airway, we should see if there's any foreign body, we can try to remove it out or not.
Yes, when you give breath, you start activate emergency response system, start CPR after placing the patient on a flat surface, and then when you give breath, open the airway and look for foreign body. And if it is seen, remove it. Very good. How to perform hemorrhage maneuver we discussed, right? Okay, this is a way you should do it, and it works. This all we discussed. Unresponsive, same, you place flat surface, activate emergency response system, start CPR, look for foreign body, but remember that no blind finger sweeps. Now we'll just quickly refresh whatever Madam said about changes in 2020. One important change is we had 5 links in the chain of survival, but it has become 6 because we have to give importance also to the recovery after recovering from cardiac arrest. So in hospital and out of the hospital, both are there, both chain of survival are there, and in that 6th link is recovery. But can you see this difference between the in hospital and outside hospital? In hospital we have early recognition and prevention, whereas outside the hospital there is first link is activation of emergency response system, right? And in hospital second link is activation of emergency response, whereas in outside hospital it is high quality CPR. Already we discussed about what are the components of high quality CPR. So this is the 6th link, that is about recovery. Then comes the early epinephrine. Madam already told it has to be given in non-shockable rhythms within 5 minutes. So the algorithm itself has been modified. You can see that the syringe is added here on the asystole or PA side. It is added here. Also you can see here lidocaine is added along with the amiodarone. You can see that in shockable rhythms. If your lidocaine is not there or not, sorry, amiodarone is not available or not working, you can use lidocaine or lignocaine. Then real-time feedback, Madam discussed. It is very important. You can also have invasive and non-invasive monitoring of quality of CPR by intravascular line. That's a invasive blood pressure of 20 millimeters diastolic has to be maintained. And somebody were asking about 40 millimeters and all that. It is 20 millimeters of diastolic pressure, and ATCO2 should be kept more than 10 millimeters of mercury. When it returns to more than 30 millimeters of mercury, it indicates return of spontaneous circulation. And also you can have a feedback device which measures the rate, measures the depth, and how many successful compressions, and also the compression fraction. What else? Then the route of drug administration has been now unequivocally it is told that IV access is best. If not available, then you can go for IO or intratrachea, endotrachea. Otherwise, the best thing is IV. And it was also emphasized in 2015 guidelines, but there were equal weightage was given to intraosseous route. Then ROSC algorithm is again updated. A lot of changes in ROSC algorithm. That is now we have to prevent hyper and hypoxia. Both are dangerous. So already somebody put in the box that saturation has to be maintained between 92 to 98%, not more, because hyperoxia is also dangerous. We have to prevent hypotension. Well, what should be the target blood pressure in post-arrest situation?
More than 90/60.
More than 90 millimeters of systolic blood pressure. If it is mean arterial pressure,
65
millimeters, right? And then targeted temperature management, that also Dr. Manasa told. We have to maintain 32 to 36 degrees centigrade for at least how many?
24 hours.
24 hours. Okay, then you can also think of percutaneous coronary intervention in case of situation like what Madam gave you. And then most important emphasis now is on neuroprotection. Neuroprotection is also discussed. So you can see here a lot of things were added in managing the airway. You can see, managing the airway breathing and oxygenation. So the respiratory rate is specified 10 breaths per minute, and saturation to be maintained between 90 to 98%. Carbon dioxide to be maintained at 35 to 45 millimeters of mercury, and the blood pressure has to be maintained this way. And then we have to have these things installed in a unresponsive patient. Target temperature management, obtain brain CT imaging is important. Then EEG monitoring and other critical care aspects to prevent hyperthermia, look for convulsions, and all these things are added. Oxygenation we discussed, blood pressure control we discussed. Then we discussed about temperature management. Very important is to avoid fever once you discontinue hypothermia, and also prevention of shivering. Right. Seizures control is very important. So EEG monitoring is advocated, and for that neuroprotection new diagram is added. You can see this. Madam also discussed it already. We are not going to go that. And after recovery, we have to give support to the victim by physical, cognitive, and psychological assessment and advice. Both are required. Multimodal rehabilitation assessment before discharge, cardiac, respiratory, neurological, and physical, psychological. All these aspects have to be diagnosed, and then a discharge plan has to be given for management of the patient at home. So multidisciplinary discharge plan has to be drafted and given to the patient, and we should encourage the return of patients to normal activity. So it requires a structured assessment and execution. Then also it emphasizes on debriefing the lay rescuers, paramedics, medical personnel, and physicians, because the especially unsuccessful rescue efforts take a toll on the psyche of the rescue personnel. So it is advised that debriefing is done after every effort, and it helps in maintaining both physical and mental outlook of the mental well-being of the personnel involved in CPR. Then pregnant victims, madam said early perimortem CS within 5 minutes. Earlier it was said that it was 4 minutes. Now it is specified that within 5 minutes we have to perform, and no algorithm has been created for that. And it stresses on welfare of both mother and fetus. Madam again told us that there is increased oxygen demand by the mother. So early airway management is advocated, and for the benefit of the fetus, you have to perform, if no ROSC within 5 minutes, perform emergency cesarean section, and do not monitor the fetus during CPR efforts because it wastes time and diverts your attention, but give oxygen and manage airway of the mother. And as soon as you ROSC achieved, target temperature management for well-being of both mother as well as fetus, and that time fetus has to be closely monitored. Then what about opioid overdose? So there have been new guidelines for opioid overdose. Especially they have updated the opioid overdose algorithms. There are 2 new algorithms for medical and non-medical people. That's a new addition. You can see here. Earlier the algorithm was not provided. Now they have provided the algorithm, and it is very clear in management. Right. Then pediatric CPR, certain changes are there. Because of lack of time, I am going to quickly tell you. Same as adrenaline to be given within 5 minutes for non-shockable rhythms. Then definitive airway, if it's available, you should ventilate at a higher rate. Somebody already told that 2 to 3 seconds once breath, or 20 to 30 breaths per minute. Then cuffed endotracheal tubes are preferred over non-cuffed, and evaluate and treat convulsions after ROSC. Post-cardiac arrest recovery patients should be having formal assessment and support for the physical, cognitive, and psychological needs, just like adults. And along with IV fluids, in case of septic shock, you can use an adrenaline or noradrenaline as a vasopressor. Earlier recommendations do not hold good. Then it's reasonable to use blood products in resuscitation in hemorrhagic shock, though there is no direct evidence. It is extrapolated evidence. It is recommended. And in case of opioid overdose, along with CPR, timely administration of naloxone is advocated, just like in case of adults in suspected opioid overdose. If you suspect myocarditis and arrhythmias, they are likely to have cardiac arrest if the conditions are existing like bradycardia, low cardiac output, and ST changes. Hence, your early admission to ICU and consideration for mechanical circulatory support. It means that you have to go for something like even ECMO, right? Right. I'll stop at this, and we are to discuss even Indian registration guidelines. There are some few more changes in pediatric, but now we are done with the time. There are Indian 3 guidelines.
So I would like to emphasize the point that when we are going for neuroprognostication and using multimodal diagnostic techniques to detect, after attaining normothermia, we need to wait for minimum of 72 hours after attaining normothermia to do this clinical tests and electrophysiology like N20 SSEP. Rather than for NSC and MRI, we can go ahead after rewarming. But to do clinical tests like for pupillary reflex, corneal reflex, and for burst suppression tests, we need to wait for 72 hours minimum after attaining normothermia.
Yes, that is
because
right.
these reflexes would be attenuated if the temperature is not attained back properly.
Then coming to briefly about IRC guidelines, there are 3 guidelines. One is COLS, compression only life support. Then BCLS, basic, that is similar to basic life support. And then is advanced cardiac life support, that is the named differently in our guidelines. One is BCLS, basic cardiopulmonary life support, and then CCLS, comprehensive cardiopulmonary life support. You can visit IRC website and read that. It is very important. You may be asked in the exams. There are a lot of differences, like the number of links in the chain of survival, the way you give compressions mostly same, but the rate is different here. It is 120 per minute. It is fixed in case of Indian Registration Council advocacy, and there are some changes like that. So now already we have crossed the time. So I'll ask Madam if she has anything to add. Otherwise, we'll close the session. Madam, do you want to add anything?
No, it's fine. Children did wonderfully well.
Yes.
Congratulations to them.
Okay, there's a question about when to stop CPR. This question is there always, and there are no clear-cut guidelines yet. But the one guideline says that if you do it for more than 20 minutes without adequate arterial blood pressure response, that is less than 20 millimeters of mercury diastolic, and ETCO2, especially ETCO2 less than 10 millimeters of mercury for more than 20 minutes, if you perform, and patient is normothermic, and there is no suspicion of any drug poisoning, in those conditions you can call off the effort. And other in this rhythm is asystole. Persisting asystole for more than 20 minutes is another indication, but there is no hard and fast rule, even guidelines even in 2020 guidelines. There is no limit for number of shocks and number of doses of epinephrine. Epinephrine is given every 3 to 5 minutes. So as long as you continue CPR, every 3 to 5 minutes you are repeating epinephrine. Okay, you all did a wonderful session. The students are very good. I think many of them are really updated, even with the 2020 guidelines. I congratulate all of you. And Madam is very, very resourceful. She has prepared wonderful slides and questions. I think the combination of our Dr. Shalom Madam and you students was excellent. All the questions were nicely answered. It was a wonderful session. I also learned many things, Madam, from you. And I thank you very much for sparing your very, very important, valuable time in training our students. Thank you very much. Thanks our hosts, our faculty, our students, and everyone. Thank you very much. And now I hand over session to our coordinators, Dr. Harish and Dr. Gandhi. Back to you. Thanks, one, and all the best to all the students.
Thank you, Dr. Shipat sir. On behalf of the organizing team, ISA Mangala, ISA Karnataka, it's my privilege to propose a vote of thanks for you all for this masterclass. My heart fills with gratitude and respect for your distinguished speakers, Dr. Shalwai P. and Dr. Shipat Mendale, for not only sparing their invaluable time for us and to grace this session of masterclass, but also for enlightening us with their thorough knowledge on the subject. Thanks to all of you for this wonderful discussion, and I hope it helped you clear any doubts about the concepts and enhancing your understanding pertaining to the topic of DR, CPR. Knowledge is a two-way street. I'm sure everyone have indeed put in their best efforts to make maximum use of this session. I'm sure the postgraduates benefit immensely from this. On behalf of the ISA Mangalore, ISA Karnataka, and the organizing committee, I thank both the speakers and the students for having for participating in this discussion. Thank you.
Thank you.
Thank you.
I'd like to give a brief introduction about Dr. Azan. Dr. Azan is a consultant anesthesiologist and critical care specialist who has special interests in ultrasound-guided nerve blocks, obstetric anesthesia, pediatric anesthesia, and critical care. He is also the author of a book, Dr. Azam's Notes in Anesthesiology, and has also written a chapter on principles of critical care in obstetrics and mechanical ventilation in critically ill obstetric patients, Volume 1. He is also an advisory on COVID-19 and anesthesia, published in the August 2020 issue of JOACP. Dr. Azan is a very good teacher and who I believe has started teaching from his PG days. I will really tell all the students to pay good heed to his class, and it will help you immensely with understanding a difficult subject called ECG, and will help you do well in your exams. I will not be wasting much time, and I will be giving over to you, Dr. Azam sir. Thank you, sir.
Thank you, Dr. Kandev. Good evening, all. At the outset, I would like to thank Dr. Sripat sir, Dr. Sushma, the entire organizing team for giving an opportunity to share knowledge and gain knowledge. And hats off to you, sir. We have started with the an excellent topic of CPR, and now going to the ECG. I think the previous speakers have made my job much easier in management. So I should just be able to tell them how to identify the rhythms. So that is what I'll be aiming. The students, can you guys switch on the video, please, so that I know who I'm speaking to? Gangdev, all the students have joined here. Okay, fantastic. All right. So as I said, the plan would be a brief history. We'll go about history. Sometimes you may be asked in the exam. Basics of ECG, then steps to be followed while interpreting an ECG. Then the various ECGs and identification. Like first, you need to diagnose that. Then we'll speak about causes and maybe requirement, maybe a treatment of few what you call important ECG strips. Yes, the other important thing is I would also like to discuss about few questions that are asked in the exam on ECG, or directly or indirectly, and we'll also speak about how to answer the same. So without wasting time, I'll share my screen. Madam, can you? Okay, I think. Okay, I'll just share my screen. Just a minute. Can you guys quickly introduce yourself, please, in the meantime, when I share the screen? The students for today's class. Can you hear me? Guys, can you hear me all?
Yes, sir.
Okay, fantastic.
Yes, sir.
You guys, quickly introduce yourself without wasting time so that we can move on.
Hello, sir. I'm Kavya from Kidwai Institute of Oncology.
Okay. Next. Guys, are you there? Gagandeep, are the students there or only Bhavya is there?
Hello, sir. I'm Dr. Hanan from KSED
Yeah.
Medical College.
Right. Next. Next, please. Okay. I think let's not waste time. You guys can hear me now? Can you hear me?
Yes, sir.
All right. So just take this. Okay. So without wasting time, as I told you, we will discuss about the brief history, basics of ECG, steps to be followed while interpreting the ECG, and various ECG and its identification, and we will discuss about few questions. So can someone tell me the importance of the history? Like when was EKG termed? What was the first, who recorded the electrical activity from the heart? Can someone tell, please? Okay, so basically in 1842, Matteucci recorded the electrical activity from the heart, and in 1887, Waller recorded the first electrical activity from the human heart. But then, Ethowin first used the term EKG, and he won a Nobel Prize for the same in 1924. And in 1954, ASA standardized the 12-lead EKG as we know now. The other question that could be asked in the exam is why PQRS letters were used, not ABCD. Can someone tell this, please? Any idea? Guys, are you there or are you able to hear me?
Yes, sir.
Yes. Can someone tell this why PQRS? Quickly. It's okay. Don't know. No problem. I'll tell you. So what happened was the letters that are used, what he chose was PQRS. This was because the A, B, C, D, and other letters were used, and the letters PQRS undoubtedly came from a system of labeling used by Descartes to design the successive points of the curve. So this is how he started off with letter P. Then first the letter that came to his mind was P, and then Q. Then it started off like that. So now, what are the conduction system of the heart? What are the conduction system of the heart? Guys, you need to answer this. Yeah, these are all basics. There is SA node and so on, right? So, what are the systems?
So, initial rhythm pacemaker is a SA node. So, from the SA node, the conduction starts and it covers the entire atrium. From atrium, it goes into the atrioventricular node. There, a time gap takes place, and then from AV node, the electrical activity will pass into the ventricles through bundle of His and Purkinje fibers.
Super. So, who was this?
Kavya, sir.
Kavya, right. So, just to say, just to just 1 second. 1 second. Okay. So, just to tell you the thing, this is SA node. You are able to see my screen? You guys are able to see my screen?
Yes, sir.
Yeah, this is SA node. This is AV node. This is internal pathway. This is Bachmann's bundle here. That is here. And then you have a bundle of, his bundle. Then we have, and these all taking off from the left posterior bundle here, that is the left posterior bundle. These are the bundle of His and the Purkinje fibers. So this is what you'll be asked in the exam that we need to know. So now here, what is the rate generated by SA node, by AV node, by bundle of His, by Purkinje fibers? Any idea what is the intrinsic rate generated by each of this? What is the rate generated by the SA node?
Sir, SA node is 60 to 100 beats per minute, sir.
Okay. 62,
Uh,
probably 80. Correct. Okay, that's fine. Then next.
AV node is 45 to 50.
Yes, correct. 40 to 50 per minute. Fantastic. Next. Bundle of
Purkinje fibers 35 to 40.
15 to 30. And before that, the bundle of his comes in. And the bundle of
That is also 40 to 40.
30 to 40. 32. So this is what you have answered. So that's very good. SA node is somewhere around 60 to 80. AV node is about 40 to 50. Bundle of his is about 30 to 40. And Purkinje fibers is 15 to 30. Right? Now, why do we need to have a 12 lead? Is 12 lead always necessary? Is there any, can we do with 6 leads? We can do with 3 leads. We can do with 5 leads. Why do you think we need 12 leads? Can someone answer? So the 12 lead ECG are used to obtain 12 views of the electrical activity of the heart. That's because the heart is considered to lie at the center of an equilateral triangle. So that is one. Now, this is another most important point, question asked in the exam is the ECG paper. You need to know a few points about the ECG paper, if not everything. Can someone tell what is the speed of the ECG paper? What is the normal speed of the ECG paper? How much are 5 boxes? One large box, those. Can someone tell me this, please? Go on, quickly. Okay, normal paper speed is about 25 millimeters per second. So one large, I can skip this and show you here. Yeah. So one large box is about 0.2 seconds, and 5 large boxes, that is 1, 2, 3, 4, 5, right? That is about 1 second. That is what. This is the standardization. This is the amplitude, and this is the one small box, which is about 0.04 second. So to make things easy, the between QRS complexes, that is the 5 large box, that is 1 second, and one large box is about 0.2 second, what I mentioned it to you here, and one small square is 0.05 seconds. This is exactly what you need to remember. This is to calculate the heart rate. I'm sure how to calculate. You all know how to calculate the heart rate. So now, how are the electrocardiogram waves are waves of the electrocardiogram produced? Like, for example, how is P wave produced? Any idea? How is P wave generated? How is P wave generated?
Atrial depolarization.
Very good. That is one. Then the early part of the P wave represents the electrical activity and generated by the right atrium. So it has 2 parts, right? It has 2 parts. So the right part, the right atrium and the left atrium. The middle portion of the P wave represents the completion of the atrial activation and initiation of the left atrial activation. And the later portion is generated by the left atrium. So the P wave is the first deflection recorded and is a small, smooth, rounded deflection that precedes a very spiky looking QRS complex. This you need to know. Likewise, coming to PR interval. So PR interval involves the time required. Basically, there is a lag between the impulse going from the atrium to through the AV node. So that is a lag. So basically, the PR interval involves the time required for the electrical impulses to advance from the atria through the AV node, bundle of phase, bundle branches, Purkinje fibers until the ventricle muscle begins to depolarize. So that lag is created by the PR interval. So QRS complexes, again, and can someone tell what is QRS complexes produced by?
Ventricular depolarization.
Very good. So it's in there. So QRS complexes represents the spread of electrical activation through the ventricular myocardium. The resultant activity enforced generate the ventricular depolarization and is recorded on the ECG by a very spike and a bigger deflection. Right? The sharp pointed deflections are labeled as QRS positive, negative, positive itself. For deflection, whenever we say negative, henceforth it will be a deflection. Can someone talk about ST segment, please? What is ST segment? What is ST segment? Okay, so The ST segment is the segment that lies between the end of the QRS complex and the beginning of the T wave. It represents the period where all the parts of the ventricles are depolarized state, or a stage in which the terminal depolarization and the starting of the repolarization are superimposed and thus neutralize each other. That is what it is. So there are few abnormal ST segments here. You giant positive, you get a giant positive T waves. You have ST segment elevations. You also have Q wave developments. Then you have persistent ST segment elevation, that is left ventricular aneurysms you can see. So hence, these are the few things that we need to know. Usually the ST segment should be at the isoelectric line, that's the flat line. Similarly, the T wave and the U wave. The T wave represents the electrical activity of repolarization of the ventricles, and it is broad and rounded wave. The T wave follows each QRS. A T wave should be there after each QRS complex by the interval and constant for the ECG. Because of the ventricular recovery proceeds in the general direction, the ventricular excitation and polarity results. So if you guys have any question, please interrupt and ask me so that it will be easier for me, because it's difficult for me to looking at the chat box. So I don't know if it is chat boxes. Okay. So when okay, you guys are answering here. Okay, fantastic. Right. Let me close this. Okay, right. So what are the, can someone tell how, when an ECG is given to you, always in the exam, never ever jump into a conclusion saying that, okay, this is VT, or this is atrial fibrillation, or this is a bradycardia, or this is a tachycardia. So there is a particular way of going through the ECG when it's given to you. So what are the 11 steps in reading an ECG? Can someone tell me that, please? This is much easier. Guys, go ahead. Can you guys go ahead? Okay. Check for the standardization. Yes, very good. Voltage, speed, rate, rhythm. Yes, okay. Body saying standardized. Okay, fine. But what are the things? So to make things easy, then you need to see about the rate, the rhythm, the rate, rhythm, P wave morphology, PR interval, QRS complex morphology, ST segment, T wave, electrical axis, U wave, and QT duration. This is what we need to see. So the step one, it would be the rhythm, then the rate. Always look out the rhythm and then the rate. Note that rhythm is assessed before the rate, because it's clinically more important, and a normal rate, that is 60 to 100 beats per minute, is easily spotted. So that is why we need to take care. The second step that you'll be doing in the ECG reading is the PR and the QRS intervals for the blocks. Is the PR interval normal? Is the QRS interval normal? Is there any prolongation of the PR interval? Or is there any problem with the QRS itself, right? So the widening of the QRS duration, such as the right bundle branch block or the left bundle branch block, we will see and in the subsequent slides. Then the P wave for the right and the left atrial hypertrophy. This is very important when you're dealing with the mitral stenosis. The step 4 would be if there is a QRS duration is increased in the absence of that is left bundle branch block or a right bundle branch block. The most important is the ST segment, as I told you. The early diagnosis of acute MI depends on the observation of the ST segment. So you need to, as an anesthesiologist, you need to keep a watch on the ST segments in patients who are ischemic heart disease, coming either for laparotomies or any surgical procedure. So new terms that have been emerged, that is now we elevation is called skimming elevation. Previously it was termed as Q wave MI. So the ST segment holds the key for the diagnosis. Then we always look for pathological Q waves. When we know in before taking the patient into the operating theater, we always look for the Q waves. We know that if there is a Q wave, the patient might have had an MI. So that is what we need to look in for. So the pathological Q waves with the prior assessment of the ST segment should determine the presence or absence of a new or old MI. This we should be able to know. And such the the loss of R wave or a poor R wave progression, which may indicate MI. Sometimes not necessarily the ST segment changes. Sometimes when there's a poor R wave progression, it should ring a bell to you that, okay, we are going to face trouble. So this patient needs to be evaluated whenever you see a poor R wave progression or loss of R wave, one of these, which indicates a myocardial infarction. Now we always looking for left ventricular hypertrophy, that's very easy, and the right ventricular hypertrophy, and T wave for inversions, right? And step 9 would be the axis and the fascicular blocks. Axis is very simple. I'll tell you the easiest way to identify the axis. The axis provides no specific diagnosis and is of just ancillary assistance only. Then step 10 is like you have other things like long QT interval, you have pericarditis, you have pacing and pulmonary embolisms. So the 11th step again, this is basically for arrhythmias, you again start. It's basically it's shadowed by the step number 1. So if you have arrhythmias, the step 11 is indeed the step 1. If an abnormal rhythm is revealed in step 1, again the same pattern flows. So this is how we come to the different steps. So now, just to summarize this, so P wave is what? Depolarization of the atria in response to SA node triggering. Filling of the ventricles. QR complex is depolarization of the ventricles triggering main pump contraction, and okay, and the ST segment is beginning of the ventricular repolarization, and it should always be flat, that is isoelectric. So 1 mm, we will get into that. 1 mm is okay, but not more than that. T wave is ventricular repolarization. Okay. Now, why do we see? We have already spoken so much about P wave and QRS complex and T wave, but what is the importance of P wave? Can someone tell what should be the width of the P wave? What should be the duration of P wave? What should be the amplitude of P wave? Can someone tell me this, please? Can you hear me? Guys, can you hear me? Hello?
Yes, sir.
Yeah, please answer here because I won't know that you guys are. I'm just talking to myself. So the importance of P wave is like P wave, 3 small squares. It should be 3. The number 3 is very easy to remember. It should be 3 like this. It should be in width. It should be 3. So any problem with 3 small squares, that means there is some problem with the P wave. Okay, so 3 small squares in duration and amplitude, and that is, it should be 3 mm. The upright in lead 1 and inverted in AVR. Okay, if opposites suspect reverse arm leads, right, and dextrocardia. So PR interval should be anywhere between 0.1 to maximum 0.2 seconds, and it may go up to 0.22 seconds in few adults. Now, what is the normal QRS duration and Q wave? Very easy. So the normal QRS duration should be 0.1 second, right? It should be less than 1 second. If it is not, consider the incomplete left bundle branch block or incomplete right bundle branch block or WPW syndrome. And obviously the normal Q wave normally present in AVR, occasionally in V1 and AVL. It often present in lead. So there are 2 phases here in QRS. There is something called brief phase and a longer phase. Brief phase is depolarization of ventricular septum, and longer phase is depolarization of the both ventricles. So there is some variation, normal R wave. There is some variation with the age. You don't have to worry much. And these are the few things which I'll be sharing with you on WhatsApp. The ST segment. I was telling you about ST segment. Isoelectric line, that is, or it should be less than 1 mm elevation or depression in the limb leads. If it is less than 1 mm in precordial leads, except for sometimes in normal variants also, you may feel the difference, but keep in mind it should be most of the time it should be the isoelectric line. If not, more than 1 mm, you consider there is something going on. Okay, the normal T wave, it is inverted in AVR and upright in 1, 2, and V3 through V6. Right. Normal axis, we will see that how to. I will give you a small example how to identify axis. How do we identify axis deviation? Can someone quickly tell what is the easiest way of identifying axis deviation? Come on. Come on, guys. You should be speaking more and I should be speaking less. So what happens to the QRS complex in lead 1? So, okay, we are taking 3 leads. To identify axis deviation, which is one of the most difficult part of ECG, you take 3 leads. That is lead 1, lead 2, and lead 3. If lead 1 is positive, lead 2 is positive, lead 3 could be positive or negative, it is normal axis. If lead 1 is positive, if lead 2 is negative, and lead 3 also is negative, it is left axis. Simple. If lead 1 is negative, the lead 2 is positive or negative, but make sure the lead 3 is positive, then it is right axis deviation, right? So now there are something about QTC interval. We have, intervals varying according to the heart rate and the male and female. These are the few examples. Now, how do we interpret, like we all spoke so much. So quick summary of this. So let's go to this a very important slide. We have electrical activity, graphic depletion, and associated pattern. If there is atrial depolarization, this is very important, and this you have to know before you appear for your exams. So atrial depolarization, you have to see a P wave. It is because of the P wave, and this is here you see in the graphics. The PR interval means PR segment or a PR interval. Then you see a big, huge spike wave, that is QRS complex, that is ventricular depolarization, which you see in the form of QRS complex. A ventricular depolarization is seen in the form of P wave, and no electrical activity is the isoelectric line. This is what I was saying, the ST segment and the isoelectric line. So now we have, we have come to the, we have understood what is what now. But only thing what I want to understand from you is what, like for example, do we see SA node when an SA node initiates an impulse? Does it reflect on the ECG? Can someone tell me this? When SA node triggers an impulse, can it be seen on the ECG? Quick, guys. Hello? Can you hear me? Can you hear me, guys? Guys, can you hear me?
Yes, sir.
Yeah. Guys, you need to tell me here. You need to answer. Others, I won't know whether my internet is gone or I'm still on. Like for example, depolarization of atrial muscles. Definitely, you see what on the ECG?
P wave.
P wave. Like that. Does SA node, when SA node initiates an impulse, do you see something on the ECG? No, you don't see anything. Yes. So that is what I was asking. Atrial contraction, do you see when the atria contracts? Do you see something on the ECG? No, you will not. Yes. So depolarization of AV node and common bundle of his, is it seen? No, it is not seen. Repolarization of atrial muscles, is it seen? Repolarization of it is not seen. But depolarization of ventricular muscles is because of what do you see on the ECG?
QRS.
QRS, very good. Muscles, do you see on ECG? See on ECG. So this is what I was asking you. And please answer me. If you guys, when I ask a question, please reciprocate, because I won't know whether I am on, I am not on. Is my net working, not working? I don't know. So SA node initiates impulse, definitely you don't see. Okay. And depolarization of atrial muscles, yeah, P wave is seen. Atrial contraction not seen. Depolarization is not seen. So only thing that you see is depolarization of ventricular muscles, that is QRS complex, and repolarization of ventricular muscles is T wave. Right. So now, in exams, this is the most common thing that you'll be asked in the theory paper. Describe the common arrhythmias encountered during your perioperative period and discuss the therapeutic of familiar. The second part of the question you neglect, because I'm not going to go into that, will not waste time. But if this question is asked about describe the common arrhythmias encountered during perioperative period, how would you answer this question? Can someone quickly tell me this? Come on, this is much easier. How do you write in the exam? How do you answer
Sir,
this question in the exam?
we have to classify them as wide complex and narrow complex QRS.
Very good. Superb. Then, very good.
Regular and irregular.
Very good. Right? Then, what is a normal heart rate?
Uh, 60 to 100, sir. Anything less than 60 and anything above 60. So
Yes.
anything less than 60 is taken as brady arrhythmias, and anything above 100 is taken as tachyarrhythmias.
Very good. Very good. Then, once you diagnose bradycardia, what do you do? Say, once you have a bradycardia, okay, now the rate is about, say, 45. What do you look for? So,
I look for the P wave and QRS complex and PR interval, sir.
very good. Okay, good. So each P wave should followed by a QRS
complex, sir.
Who is answering this?
I'm Dr. Hanan, sir.
Who is answering this?
Hanan, sir.
Hanan, right. Fantastic. Yeah. Excellent. Then okay. Hanan, right. So each P wave should followed by a QRS complex. After that, suppose say you have a P wave, then you have a QRS complex. Then what is the next step that you're looking for? So between P wave and QRS complex, what is that?
PR interval, sir.
Very
PR
good.
interval.
Check for the PR
If it is
interval.
normal or prolonged or narrow.
Correct. Go ahead. Very good. If it is prolonged, what is the diagnosis?
I'll see for the next, I'll look for entire strip, sir. If the PR interval is repeatedly prolonged or they are equal in all the complexes, sir.
Very good. So if the PR interval, okay, if the PR interval is normal, okay, that is about 0.12 second, maximum to 0.2 seconds, right? If it is normal, then what is your diagnosis?
Sinus bradycardia, sir.
Very good. Sinus bradycardia. Excellent, yeah. Excellent. So the next thing is when your PR interval is prolonged, okay, when your PR interval is prolonged, then you have three diagnoses. First degree heart block, second degree heart block. In second degree heart block, you have Mobitz type 1 and
type 2, sir.
Very good. That is what we are asking. Suppose say there is no relation between P with QRS complex.
That is third degree heart block, sir.
Complete heart block. Yes, complete heart block. So that
RR and PP.
Yes. So this is exactly what I was trying to get it from you. In the exam, whenever a question is asked on this, it is important to write in this format. So the flowchart is easier for the examiner to correct this. This is called as mind mapping. This kind of presentation is called mind mapping. And can someone mute your mic, please? Can someone mute your mute? So this is called mind mapping, where this way of writing or learning, it is easy to learn and easy to reproduce in the exam. So I would suggest for all the students to follow this mind mapping. Please Google about it. It's a fantastic. I have used it and I find it much easier. So what you were saying was anything less than 60 is bradycardia, anything more than 100 is tachycardia. Very simple. Which we said anything less than 60 is bradycardia. Then we look for a relationship between P, Q, RS. So each P wave followed by QRS complexes. Check for the PR interval, whether it is normal or prolonged. If it is prolonged, we said it is first degree, second degree. In second degree, it could be type 1, type 2. We'll see further what happens. And normal, if it is normal, sinus bradycardia. That limb finishes. If your heart rate is between 60 and 100, it should be 100, and it is normal, and you think of atrial ectopics, ventricular premature, VPCs, that is ventricular premature contractions. Now, again, before that, sorry, I forgot the other limb. If there is no relation between the P wave with the QRS complex, the P wave marches through the QRS complex, then it is complete heart block. So we finished this part of the limb. Now we also finished this part. Now coming to the, if the heart rate is more than 100, so it is tachycardia. As you said it is narrow complex and broad complex. So now how do you go about? Tell me, how do you what? If it is narrow, broad complex, what is? Come on. For narrow complex, what do you look for?
Again, we have to
Whether
see
you
if
look, it is
P is
first,
follow.
correct. Before that, before regular or
Regular or irregular, sir.
where if you like first you see heart rate is more than 100, you diagnose it as a tachycardia. After that, you see whether it is narrow complex, broad complex. Let us see about narrow complex. Once you have diagnosed it's a narrow complex, then you see P wave, whether it is positive, P wave is present or P wave is absent. If P wave is present and it is a tachycardia more than 100, narrow complex, P wave present, what is your diagnosis?
Sinus tachycardia, sir.
Very good. That's it. If there is narrow more than 100 tachycardia, narrow complex, but P wave is absent,
Ventricular tachycardia, sir.
or it could be PSVT.
Yeah, PSVT.
Supraventricular tachycardia, because your P wave might be hidden in the QRS complexes. That is one. It could be AV and RT. It could be atrial fibrillation. Correct. When think of causes where P wave is not seen. Simple. Okay, with 2 in 1 block, it could be 2 in 1 block with AF inhibition. Now, coming to irregular. Okay, so tachycardia, I'll go to the next slide, maybe you'll understand. Here, so we discussed about this regular, P wave plus, P wave minus, that is P wave not there, P wave is present. So now we have finished this. Coming to irregular, if there is P wave present, we have two diagnoses. What is it? If P wave irregular, so tachycardia, narrow complex, irregular, P wave present. What are the diagnoses?
Atrial fibrillation or atrial flutter, sir.
No, in fibrillation, you may not see P wave. So in atrial flutter, you may see P waves. So this is one it is. Then coming to broad, the broad complex, it could be regular, irregular. Irregular is what? Very easy. Irregular is ventricular.
Fibrillation, ventricular fibrillation.
What is irregular? Broad fibrillation. Yes. And if it is regular, it is ventricular tachycardia. It could be SVT with aberrant contraction. The bottom rule is, if there is a broad complex, if you are not sure, even if it is SVT with aberrant contraction, you treat them as ventricular tachycardia, unless proved otherwise. Okay, you don't have to waste time for that. So this way, you need to answer your question in the theory. Clear, guys? Clear? So what I have done is I've written few causes here. There are about 13 causes. These are the causes which can trigger off your arrhythmias in the operating theater. It could be tracheal intubation, halothane, ketamine, local anesthetic. You name the thing, it will be there. So this is much easier for you all. So what are the causes for abnormal P wave? Now let us come to each analyzing of each wave. So what are the causes for abnormal P wave? Come on. So the P wave, it will get up, the P wave gets abnormal when there is an atrial hypertrophy. Okay, so as I told you, to make it very simple, I have written it should be peaked more than 3 millimeters or broad more than 3 millimeters. So here I have shown some of the P wave abnormalities. It could be normal atrial ectopic. This is how you look like in atrial ectopic. It will be a very small deflection, and in pulmonary it will be more than 3. It is a tall P wave. In P mitral there will be notched. Simple. So if it is peaked, right atrial hypertrophy, right atrial enlargement, and the causes for that RVH, that is right ventricular strain, and other features of pulmonary embolism. If it is broad P wave, which is P mitral, then you have left atrial enlargement. Check for the mitral stenosis, mitral regurgitation. It could be LV failure, dilated cardiomyopathy, LVH, and causes of the LVH. Guys, clear? Are you guys clear? Are you guys
Yes,
clear?
sir.
Are you guys clear? Are you able to hear me here?
Yes, sir.
Answer. So we'll move to the next one. So what is the criteria and causes for sometimes these QRS complexes will be very small and we call that low voltage QRS complexes. So why do you think we see low voltage QRS complex? Any idea? What are the causes? What is the criteria to take it is low voltage QRS complexes? In all the limbs, the amplitude of the entire QRS complex, that is R plus S, is less than 5 mm. That is one of the criteria to say it is low voltage QRS complex. In each of the precordial leads, the amplitude of the entire QRS complexes, that is R plus S, will be less than 10 mm. It's a very simple criteria. So the causes will be obesity, pericardial effusion, concentric pericarditis, hypothyroidism. You know, there are so many causes which goes on and on. So these are the few things that you need to remember, and sometimes the examiner will ask you this, and this is what you need to say. How do you approach ST segment elevation or ST segment what do you call depression? Any idea, guys? So now this is what I was saying. This is called mind mapping. This way of presenting is called as mind mapping. So once you assess for the ST segment elevation or depression, right? If there is ST segment elevation or depression, if it is more than 1 mm elevation in 2 or more limb leads, that is 2-3 AVF, then it could be acute inferior wall MI. If it is 2-3 AVF, okay. If 1 mm elevation in 2 or more, again precordial leads like V1 to V6, then it is acute anterior wall MI, and this will lead to ST segment elevation myocardial infarction. So same way, if there is no elevation, if there is ST segment depression by 1 mm in 2 or more leads, then if it is present, then you do what? Tropi or CKMB. If there is of this on segment elevation MI, if there is not elevated, you can still think of that. If there is abnormal ST segment elevation, can be caused by the following. It could be because acute MI, coronary artery spasm. It could be acute pericarditis, aneurysms, left bundle branch block, right bundle branch block. Now, if there is ST segment depression, it is ischemia. If there is ST segment elevation, there is a current injury that is going on. And if there is Q wave infarction, it could be old, or it could be necrose, or it could be already infarcted. This is how we go over. So how do you identify the infarct size? Now say by ECG, it's very easy to identify the infarct size. Approximately, if not precisely, what you can do is, if it is a small MI, okay, if the MI, though there are no words, but somewhere I read about this important thing of small MI, the ST segment elevation in 2 or 3 leads. If you see ST segment elevation in only 2 or 3 leads, it is small MI. Moderate MI is 4 or 5 leads. If it is large MI, it is 6 or 7 leads, and extensive MI, it is about 8 or 9 leads, right? This is how you need to identify on the ECG. Can someone quickly classify this cardiac dysarrhythmias? This is also one of the questions that can be asked in the exam, theory exams. How are cardiac arrhythmias classified? Can someone classify, please? Guys, can hear me? Hello? You guys can hear me? Okay. Can you guys hear me?
Yes, sir, we can hear you.
Okay, please answer here, otherwise I'll be confused. Okay, so the whenever a classification question is asked on the classification, this is what again mind map. Classification arrhythmias can be classified as junctional rhythms, supraventricular dysarrhythmias, heart blocks, ventricular arrhythmias. So there are 4 headings under classification: supraventricular dysarrhythmias, heart blocks, ventricular arrhythmias, junctional rhythms. Supraventricular, which is very important for us. Supraventricular arrhythmias: atrial ectopics, atrial tachycardia, atrial bradycardia. Atrial tachycardia is SVT, PSVT, paroxysmal supraventricular tachycardia. Atrial fibrillations, atrial fibrillations, and atrial bradycardia. Simple. Slim is finished. So arrhythmia will be classified supraventricular, junctional rhythms, and heart blocks. Okay, heart blocks again: first degree, second degree, and third degree, or a complete heart block. First degree is first degree. Second degree again 2 types: type 1 and type 2, Mobitz type 1, Mobitz type 2, complete heart block. Then you have bundle branch block. In bundle branch block, it could be LBBB, RBBB, left ventricular hemi block, left posterior hemi block. All this I'll be sharing in the on the emails that you have provided me, so don't worry. And this ventricular arrhythmias, again, which is very important, ventricular ectopics, ventricular tachycardia, ventricular fibrillation, or WPW syndrome. The junctional arrhythmias, nodal ectopics, it could be tachycardia, that is nodal tachycardia or AV dissociation, or it could be nodal bradycardia. This is exactly how you're going to replicate in the ECG. From now on, I want you guys to identify this ECG. That is right, wrong, forget about that. We are here to learn. I am also here to learn from you all. From now on, I'll show you ECG and you will interpret this for me. So what is this ECG? Please identify this ECG, one of you guys. Yes, go ahead, Deepika. Go ahead, yeah. Can someone go ahead, please? Just interpret this, very simple. What is the heart rate here? Is it regular? Is it irregular? What is the rhythm?
Sir, it's sinus arrhythmia, sir.
How did you say it is a sinus arrhythmia? Correct. Your answer is perfect. I want you to identify to say what is the heart rate in this ECG? Anywhere between?
Sir, it's around 70 to 80, sir. In between, it's around 75.
Very good. Very good. Okay. Is it regular, irregular?
It's a regular rhythm, sir.
No. How
Because
can you say it is regular? See the distance here, 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 and here, here, and here, and see this. See the distance. So it is. Rhythm is
irregular, sir.
Very good. So your rhythm is irregular. Okay. That is, there is more than 10% of variation in the PP interval. So between this P wave and this P wave, there's variation. See here, this P wave and this P wave is smaller distance, but here this P wave and this P wave, there's quite larger interval, right?
Yes, sir.
P wave is appearing before QRS complexes.
Yes, sir.
Very good. So it is there. QRS complexes is less than 0.12 second. It's a narrow complex, so it's quite fair, right? So what is the treatment of this? Okay, why is the sinus arrhythmia happen? Any idea?
Sir, it's a normal variation, sir. There is increase in heart rate there is decrease in heart rate during inspiration, and there is increase in heart rate during expiration because of vagal tone, sir. So this is a normal variation.
Heart rate increases with inspiration. Excellent, excellent. So who is answering this?
Sir, I'm Deepika, sir.
May I know your name?
Deepika, sir. Deepika.
Right, Deepika. So got it, Deepika. So it's used. Why this happens? Why this happens? What is the reflex behind this? The heart rate increases with inspiration. The heart rate increases with inspiration. Do you agree with me?
Yes, sir.
Okay. Next, what happens is it refers to change in the sinus node rate with the respiratory cycle. So on inspiration and expiration, this is quite common in young, healthy individuals and have no clinical significance. Which is a reflex behind this? Inspiration. What is the reflex? Brain bridge reflex and decreases with the expiration. Okay. So most of the times patients remain asymptomatic, does not require any treatment. If at all you require, the condition you can use an anticholinergic agent. In most of the patients, it increases. Can you identify this, please? Very simple, very easy. Can someone identify this? I'll play again. Come on, very simple. Can you see somewhere here what's happening to the heart rate here? What is the heart rate here? 1, 2, 3, 4, 5, 6, 7 almost. What is the heart rate, approximate heart rate? Divided by 1, 2, 3, 4, 5, 6.
Around 45, sir.
Exactly. So what is this? You see P wave? Do you guys see P wave here? Is P wave seen?
Yes, sir.
Yes, sir.
So P wave is seen here and also here. And QRS complex is narrow. What has happened to the PR interval? Is there any prolongation? It is almost the same. Correct? It's almost the same. So PR intervals is remaining the same. Correct? So you need to go back to this. You need to have an idea of this. So P is followed by QRS. Then we look for P wave followed by QRS complex. It is there. The PR interval was normal. So what is it? So what is this again? What is this again?
Sinus bradycardia.
Very good. So this is sinus bradycardia. So how do you treat bradycardia? Symptomatic, asymptomatic. I think sir and madam has told you this in the last class. What is the treatment for asymptomatic bradycardia or symptomatic bradycardia? Symptomatic bradycardia?
Sir, injection atropine 1 mg, sir. Can be repeated up to 3 mg maximum, sir.
So why 3 mg? The vagolytic dose of atropine. So the vagolytic dose, according to the Lee synopsis, is about some books says about 2.5 mg. So some few books says about 3 mg. So 3 mg is fine. So 3 mg is the vagolytic dose of atropine. Okay. If it is not responding, then if the BP is very low and not responding, then what do you do?
So we can use adrenaline, sir.
Fine. So what is the, say you have given regional anesthesia, you see bradycardia. What is your inference? What is it because of? Coma and convulsions above 3 mg. Okay, vagolytic dose. Yes, you guys are answering. This is, I mean, it's getting a little difficult for me to see the chat, but however, high spinal. Okay, why high spinal? At what level? At what level do you see bradycardia?
About T4.
Cardioacceleratory fiber. Sorry.
T4 and
T1
above.
to T1 to T4. That is where the cardiac acceleratory fibers are. Okay, fine. These are that is how your Viva will go into the exam, right? So next, can you identify this, please? Can you identify this? Can you see something here? This one. Can you see here what is happening? I'll play again.
Prolonged PR interval, sir.
No. It's not a prolonged. See, between QRS, you're getting, see, between these two QRS, you're getting one more spike here, small spike. And if you go back to this slide of mine, how does
P pulmonale, sir.
P mic.
No. Okay. No, it's not P pulmonale, neither it's P mitral. P waves are there, but then this is a atrial ectatic. That is premature atrial contraction. How to diagnose this? Very easy. Okay. Sometimes you see a big wave. Sometimes see there is a irregular rhythm. So that's why they say first you need to see the rhythm more than anything else. You see the rhythm first. So there's irregular rhythm. Heart rate will be predictable, but sometimes it could be fast, it could be slow. It is irregular, and a P wave premature, abnormal, and maybe sometimes that is what is happening in this. P wave is hidden. P wave is hidden here. These are the premature. The best way to identify, guys, the best way to identify a premature atrial contraction is your plethysmograph. Put a patient on plethysmograph, you can see the readings. The beautiful plethysmograph will suddenly have a small spike. That is how you identify. It's very common. The common causes are stress, caffeine, tobacco, whatever. And PACs, most of the premature atrial contractions do not require any treatment, right? So, but then, however, you need to evaluate them further. Now, what is this? What is this? I'll play you one more. Now at least. Okay, first, is the rhythm regular or irregular? Is it regular? Here, just see this.
Irregular, sir.
Irregular, yeah, simple. So, is there a P wave seen? I can see a P wave here. I can see a P wave. So first of all, heart rate is about 100.
110.
Yeah, 110. Yes, approximately 100. So it is narrow complex, broad complex. That is why.
Narrow complex, sir.
Yes, that is why those steps are very important. Narrow complex. So P wave and QRS complex, is there a relation? Yes.
Yes, sir.
Yes. So what is your diagnosis?
Atrial flutter. Atrial fibrillation. Flutter.
These are the fibrillating waves you're seeing here. Okay, these are the fibrillating waves. You know, that is why it is atrial fibrillation. To identify, the ECG shows P wave, or which are maybe clear, maybe sometimes may not be clear. That is one. QRS is usually there. Heart rate can vary depending upon whether it's slow AF or a fast AF. The most important thing, what is the single most important cause for atrial fibrillation? What is one thing that you would like to check pre-anesthetic evaluation? What is the most important electrolyte that you would like to see? Come on, simple. What is the, I'm giving you a clue, which is the electrolyte that can cause atrial fibrillation? Potassium. If it is hypokalemia, so you always, first, the most commonest cause for atrial fibrillation is electrolyte imbalance, and the most commonest electrolyte is potassium, and the most of the times it is hypokalemia. And hypokalemia sometimes may not get corrected if there is underlying hypomagnesemia. So you may also have to look in for hypokalemia and hypomagnesemia. And these are the few causes. And we all know the treatment. Intravenous beta blockers. You need to slow down the rate if it is fast, because it can compromise your cardiac output. I think I heard Madam mentioning about, if there is hypotension, what do you do? If there is hypotension, AF with hypertension, what is the management? I think the previous madam and sir were talking about this.
Cardioversion, sir.
Before doing cardioversion, what would you like to rule out? Clot, yeah, it is written here. If it is chronic, because you won't know whether it's acute or chronic. So if it is chronic, then you always rule out clot in the atrium, and it can take off, right? Clear? Can we move forward? Yes. Go ahead now. This is much easier.
It's atrial flutter, sir.
Yes, very good. Can you now make out the difference between this and this? See this? This is atrial fibrillation. That's fibrillating. It's fibrillating. Atrial flutter is very easy to make out. Sawtooth. Correct? See this now. I'll play this. You understood now? Are you able to make out the sawtooth here? So that is what is atrial flutter. Now, how do you diagnose this? Atrial rate can go up to 240. Sometimes the maximum recorded rate is about 240 to 350, but it can be slow also. Lesser than that, the sawtooth appearance pattern between QRS complexes, that is the diagnosis of this. And many a times it's a regular rhythm. If you go back here, see the rhythm. It's a regular. The QRS complexes are regular. There's no change. 1, 2, 3, 4. 1, 2, 3, 4. 1, 2, 3, 4. It's almost regular rhythm, right? So that is how you diagnose. And ventricular rate can vary based on the conduction. And what are the causes? It is valve diseases, especially mitral valve. Coronary artery disease, you need to take care of hyperthyroidism or thyrotoxicosis sometimes, and COPDs and obesities. What would be the treatment? Even know. The examiner's favorite question: what is the dose of diltiazem? What is the dose of diltiazem? So anyway, now the next question that can be asked in the exam is the classification of heart blocks. So we said the first degree heart block, but block very easy. It could be RBBB, LBB, left anterior hemi block, and left posterior hemi block. And then you have first degree, second degree. There are two types. That is Wenckebach's or Mobitz type 1 and Mobitz type 2. And you have complete heart block. This is very simple. So now, what is this? What is this? Is the rate okay, or there is variable in the rate?
Rate is okay, sir.
Okay. Rhythm? Rhythm?
It's regular, sir.
Yes, it could be regular. Sometimes it could be okay. Very good. P wave identical before each QRS. Okay. See in V1 and V6 what's happening in V1 and V6. V1 and V6. This ECG is not right. It's not exactly showing, but definitely. So it is right bundle branch block. How it bundle branch block is simple way. RS R dash pattern, which I don't. RS R dash maybe you can see here, not in V6 typically, but basically you need to see in V1 and V6, right? So RS R dash pattern and QRS comp in V6. So that is how you, in fact, you can see here. I think here you can see some amount of this pattern. So it is not so deep. Sorry, so deep here, but you can still make out. Anyways, so the rate is maybe it could be variable. The rhythm may be regular or irregular. P wave identical before each QRS. You will have a P wave, and PR interval 0.12 seconds, maximum to 0.2 seconds. But QRS complex, it will be 0. It will be more than 0.12 second, and R dash pattern in V1. That is this picture you remember here. You guys should remember this picture so that it comes to your mind. R dash RS in V1 and QRS in V6 gives you RBBB pattern, right? What are the normal causes for this? It could be because of any heart diseases, coronary artery disease, cardiomyopathies. Then you are associated with right ventricular hypertrophy. How do you treat them? Right bundle branch block may not require treatment always. Sometimes, if it is too much, then you may also go in for a resynchronization therapy. Maybe you may require a pacemaker. Right. Now, what is this? V1 and V6 again. V1 and V6. So you see somewhere M here. Can you, though it is not very typical, we can make out the, it should be a typical M. So it is a left bundle branch block where here the rate is variable again. The rhythm may be regular or regular. We all know that. And PR interval is quite okay. No problems with the PR intervals here. QRS is brought 0. And you see guys and or in V1, ST segment could be elevated and notched mid. That is the most important. Whenever you see M, this is the M pattern, that is the LBBB. If you see RS R dash pattern, that is RBBB. It's the simplest way of remembering, right? Now, what are the causes for this? Acute myocardial infarction, it could be aortic stenosis, coronary artery disease, dilated. Many of the times, the dilated cardiomyopathies can have always RBBB or LBBB. So you need to be careful when you're managing this. Then disease of the electrical conduction system itself, or in a patient who is having long-standing hypertensions, can cause this. Again, treatment, artificial pacing if required, otherwise resynchronization therapy can go on. Now, next ECG. This is simple. Next ECG is what happening. what is happening to rhythm? Just look at the, okay, there is a P wave. There is a P wave. Is there a P wave there? Is a P wave?
Yes, sir.
Yes.
Yes.
Very good. So P wave is present. So P wave is present here, right? So then what happens to the rhythm? Rhythm is regular. It's almost equal. Almost equal. Correct? It's almost equal. But what is happening to the PR interval? P and R interval. Can you see this is?
Prolong, sir.
Yeah. So the P wave should be much closer to the QRS complex. But here the PR interval is getting prolonged. So what is this? PR interval is getting prolonged. It is
First degree.
first degree heart block. So this is what it is. So the PR interval will be more than 0.2 seconds. And QRS complexes are narrow again here. That is less than 0.12 second. The most commonest causes, again, there are a few causes here: myocarditis, digital toxicity. It could be pre-existing, increased vagal tone. So you need to be careful. Hyperkalemia can cause this. So treat the underlying cause and careful may progress into AV block. So first degree is okay. It's not that bad. We can manage the patients with first degree heart block, right? So next, what is this? What is happening? So the rate is variable. You agree with me? Rate is variable. This rate is different here. The rate is different here. You agree with me or no? What is happening to the rhythm? It's regular or irregular? Come on.
Irregular, sir.
Irregular. Very good. And what is happening to the conduction of P wave? There is P wave. There is P wave. Also here PR intervals. So there is intermittent conduction of P wave and PR interval. What's see here? The P wave, P interval. What's happening? PR interval. Sorry, there is normal here, slightly getting prolonged, getting more prolonged till the P wave is dropped. Right. So there is a prolongation of the PR interval. So if there is prolongation of PR interval, what is the diagnosis?
Mobitz type 1.
Type 1. So how do you identify this? Again, simple. Again, rate can vary. Rhythm is irregular and intermittent conduction of the P waves. Right? See, there is almost the P wave is P wave are dropped. That is the P wave interval increasingly prolonged until a P wave is dropped. That is how it is. And the QRS complex is always normal. That is 0.12 second. That is how you identify Mobitz type 1. Is morbid type 1 dangerous or morbid type 2 is dangerous? What is this now? Again, heart rate is variable. You agree with me? What happens to the rhythm? It's a regular or irregular? What happens to the rhythm? Fast. We have 15 minutes. We have many more slides to go. What happens to the PR interval? Maybe normal or maybe prolonged, but it is constant until the P wave is blocked and not conducted. See, P wave is here. P wave, it's normal here. Again, it's normal here, but there is no QRS complexes here. So it is Mobitz type 2, where the P wave normally normal with the constant PR intervals. So there is a constant PR interval. QRS complexes are sometimes more than 0.12 second, 0. More than 12 seconds, and PR interval may be normal or may be prolonged sometimes, but it is constant until a P wave is blocked and it does not conduct. So if you see here, there is P wave, but there is no conduction. It just stays there. There is no QRS complexes at all. There is a drop beat. So this is the causes are anterior MI, cardiac surgeries, again mitral valve repairs. You see this hyperkalemia, drugs like beta blockers, calcium channel blockers, digoxin. These are the one who require. So whenever you see a patient preoperatively who are having second degree morbid types 2, these are the patients who will require temporary pacemaker, right? This block usually occurs below the bundle of his and more likely to progress for complete heart block. That is why Mobitz type 2 is much more dangerous than Mobitz type 1, because they can go in for a complete heart block. What is this ECG? I'm sorry for the it's not very clear. So what is this? What is happening to P wave? Is P wave there? So it is complete heart block. See again, there is P wave is normal, but there is AV dissociation with the atrial, that is P wave generated than QRS. There is no relationship between these two, and ventricular escape beats are usually about 25 to 20 beats. See, there is no relation at all. Can you make out here? Can you make out here? Oh, you guys are answering on the chat. Huh? Shit. Okay. So fine. Complete heart block. Very good. I think Bhavya, Rashmi. Okay, you guys are answering here. Okay, let me keep the chat box open. Okay. So this is how it is. And the causes are complications of heart block, coronary artery disease, radiotherapy, infections, and medication. Now, never ever take them to the theater because you have to get them, get them into permanent pacing before you take them for surgery. Otherwise, you're getting into deep trouble. Sometimes they do not respond to atropine. Though the treatment is atropine, sometimes they fail to respond to the atropine. Right. So what is this? I'll just play this ECG. This is easier. This you see every day, day-to-day practice.
Ventricular premature complexes.
Very good. So ventricular, premature ventricular ectopics. So very simple. The rhythm is irregular with the ventricular premature ventricular contractions, right? The causes again too much of caffeine, alcohol, metabolic causes. You need to rule out acidosis, hypokalemia. The treatment is very simple. What I should say is asymptomatic patients, they usually don't require, but at least if it is too much, you can ignore. This ECG, this you should not be missing this. This is very simple. And this is also an examination question, theory question. Do you see P wave here? Yes, very good. SVT. Shabnam, Sahana, Kalyani. Very good. SVT. This you should not be missing here. Actually, the P waves in the ECG that is lower, the P waves are hidden. What you see is a Q wave, right? So the P wave is small deflection there. There's a small deflection here. Those are the P waves, which are usually hidden in QRS complexes. So it is an SVT, right? Supraventricular tachycardia. Now, this is what I was trying to tell you. This is a mind map. The causes are sepsis, idiopathic. It could be idiopathic, congenital heart disease, thyrotoxicosis, excessive coffee. Certain drug causes this, right? What is the treatment? Again, you have to classify them. Hemodynamically stable, hemodynamically unstable. Like Madam was mentioning and Sir was mentioning, hemodynamically unstable cardioversion. Always remember, the easiest way to remember is atria requires little higher joules, ventricle requires little lower joules during cardioversion. In SVT, you require about 50 to 100 joules, where in atrial fibrillation you require about 120 to 200 joules. The pharmacological treatment would be very simple. If the patient is hemodynamically stable, you have valsalva maneuver, carotid massage, adenosine, varapin. Simple. Next, this you will not miss. From now on, you will not miss. What is this?
Ventricular tachycardia, sir.
Very good. Should I play this? Okay.
Monomorphic VT.
Very good. So this is ventricular tachycardia. So what do you do? Oh, sorry. What do you do here? Ventricular tachycardia. Suppose say intro you dub ventricular tachycardia. What do you do? Very good. Muzammil will check for pulse. Yes. Monomorphic VT. Agreed. That is the diagnosis. Very good, because everything looks the same. So what do you do? What do you do? Intro. Pulseless with pulse. Okay. Unstable. Yes. With pulse is cardioversion. Without pulse, it is defibrillation. So heart rate, it can vary from anywhere between that. Rhythm, there are 3 or more ventricular beats. There is no P wave, there is no QRLS. P waves are absent. QRS are quite wide, more than 0.12 seconds. and symptomatic VT, there should be causes like 100% this patient, most of the time these patients will have coronary artery disease, or they may be going in for a myocardial infarction. So these are called as pre-arrest rhythms. So that is what we need to do. And congestive heart failure with ventricular aneurysms. So symptomatic VT with detectable pulse should be managed with urgent synchronized cardioversion. VT pill with pulse is synchronized cardioversion. VT without pulse, your CAB and follow, right? So you need to defib them and start CPR. What is this?
Ventricular fibrillation, sir.
Very good. Same way. Again, it's a pre-cardiac arrest rhythm. So you got to be very careful in dealing with this. And patient can get arrested. So you need to start CPR and follow all your ACLS protocol, which already has been touched by madam. What is this?
Polymorphic ventricular tachycardia.
No. Just see what's happening here. What's happening here and what's happening here.
Torsades D pointus, sir.
Very good. Torsades D pointus. What is the most commonest abnormality, electrolyte abnormality, or the treatment of this?
Magnesium sulfate is the treatment. IV magnesium sulfate.
What is the maximum? Okay, IV magnesium, correct. So this is what it is. Torsades D pointus. The causes is electrolyte imbalances most of the times, hypokemia, hypomagnesemia. Sometimes hypomagnesemia is associated with hypokalemia. So myocardial infarction, drugs which lengthens the QT intervals and the security rate can be seen in these patients. If it is synchronized cardioversion is indicated and usually should get corrected with magnesium. Many a time you have seen getting it corrected with the magnesium. The most important thing is what are the electrolyte imbalances can you enumerate the ECG changes and electrolyte abnormalities? This is what will be asked in the exam. Can someone answer, please? What is this? Though ECG is not clear, I'm sorry for this. I will not go into. You can see the small. What are these waves here? Small hump.
Sine wave pattern, sir.
T wave. After T, what is this wave?
U.
U wave. U wave. Okay, someone was asking to repeat the Torsades D pointus chart. This is what it is. It is there. I'll share you. Don't worry about that. I'll share you on the PDF as organizing sir has given us the permission to share, so it should not be a problem. And this is hypokalemia. So how do you identify hypokalemia? PR interval may be prolonged. QT interval may be prolonged. There will be ST segment depressions here. And the T wave flattening goes on increasing. U wave is present. That is potassium of less than 2.7 milligrams per liter. That is how you diagnose. What is this? Come on.
Tall and peak T waves, sir. In case of hyperkalemia, it is seen.
Very good. Excellent. Yeah. Who is this?
Deepika, sir.
Right. Excellent, Deepika. So hyperkalemia, you will be asked at what potassium levels you will see what. So what is this pattern called as?
Sine wave pattern.
Very good. Yes, sine wave pattern. So P wave decreases in size or lost. PR intervals are prolonged. Tall T waves. QRSs are widened. At the end, you see sine wave pattern, and sometimes there will be a resistance. So sometimes you need to go in for a pacing sometimes. And these guys, the guys who require urgent dialysis or not responding to your normal regular therapy. So at 4, this is what you see. Okay, that is normal. Peak T waves between 6 to 7. Flattened P waves and between 8. Standstill will happen between 8 to 9. And sine wave pattern is more. If you don't read, they're going for a flat. What is this? What is this? ST segment. What is happening to ST segment? P, Q, R, S, and T. What is happening? It's prolonged. ST segments are prolonged. Correct? You agree with me? See here, P in lead 1. Can you see my cursor here?
Yes, sir.
Okay. So P wave, Q, R, S, and T. So there is ST segment prolongation. Yes, QT prolongation also. P, Q, and T also is getting prolonged. So it is seen in hypocalcemia. ST segment prolongation, QT interval prolongation, and VT. Clear, guys? Right. Next. Come on, what is this? It is short QT interval. It has a short QT interval, primarily due to short ST segment. Gradually, ST segment start disappearing. Okay, the SNT is getting, yeah, depression is there, Mira, but then they start getting, they start disappearing, and there is incorporated into T waves. The ST segments are getting incorporated into the T waves here, right? And this is because of hypercalcemia. The landmark of, identification points is short QT interval, primarily due to short ST segment. Gradually, ST segment disappears, incorporated into T waves. Arrhythmias like atrial and ventricular, especially patient is taking on digoxin. So hypocalcemia, QT prolongation, hypercalcemia, QT shortening. That is how you remember. Next. Come on, this one. QRS is slightly widened, but you cannot make out very clearly here. And the PR interval is what happened? PR interval. Slightly getting prolonged here. So there will be prolongation. T waves are, what has happened to T wave? T wave, they are slightly inverted. Though you see U waves here also is present. U wave also is present. U waves are present. U waves are present. So it is hypomagnesemia. How do you detect this? There'll be PR interval prolonged. QRS is widened sometimes. Okay, it will be little more than 0.12 seconds. T waves are inverted. Sometimes it could be upright, but U waves are present. And if you don't treat them, they go into what? Prosthesis, the voices. Yes. What is this? Go. Yeah, you can make out. You can make out. This is digoxin toxicity. The classical digoxin has a down-sloping segmentation, also known as inverse tick mark or hockey stick sign or reverse check sign. This is what you see here, right? Digoxin toxicity. This is inverse tick sign. Inverse tick sign. Right. Now, there are sometimes you'll be asked in the exams what lead represents what. So I thought I should put this slide here. The lead one is lateral. Inferior is what leads? Inferior is 2, 3.
ABF, sir.
AVF. So one AVL and V5, V6 are lateral. Then you have septal leads. Then you have anterior leads. So sometimes they will ask you about this, and you need to be able to answer this. Right. Last. What is this? This is so easy. Huh? What is this?
Asystole.
Jalaram, yes, it is asystole. So what is a flatline protocol? What is flatline protocol? One fast. What is flatline protocol? Check the lead attachment, check lead connection, power on or power off sometimes, and check the gain. This is before you call it as asystole. This is what you need to check. So this is where I finish. There's a beautiful quote by Ratan Tata. It says, "Up and downs in lives are very important to keep us going, because a straight line even in non-ECG means we are dead." So this is what it is, and it is not very difficult, guys, as postgraduates. It's not very difficult to learn things and precisely. By this, what I would I'm sharing this picture because this is one of my picture where in India I stood ninth on photography contest. What I'm saying is, if you pursue,
Hello.
if you can you hear me? Case, can you hear me?
Yes, sir.
Okay.
Sir, I'm Josna. I have a doubt, sir.
Yes, Joseph.
Sir, can you explain about 2:1 block and that 3:1 block, sir?
Yeah, what I will do is, since we have a WhatsApp group, I will explain to you, and I'm sending you the PDF on the same, so you can refer that in view of it's already 9 o'clock here. Okay, So I will definitely, just in case if I don't answer, just send me a WhatsApp message. I will answer to your point. Okay.
Okay.
So what I'm
Thank
trying to
you.
tell you here is, anesthesia, we should be the best. No matter what, we should be the best, and and the anesthetists are best in the procedures, particularly airway management. We are the perioperative physicians. We take care of any medical illnesses that are there intraoperatively, and we need to be. So what I'm trying to tell you is, if you can pursue our career, we can achieve anything in this life. So all the best. And any questions that you have, you please post it on the group, because of the time constraints. It's already 9:05. Not fair to continue like this for more period of time, because ECG is such a vast subject. What I have touched is very superficial. So thanks for your kind attention, and I will share the PDF in next couple of hours. So thank you.
Thank you, sir.
Sharing my
Thank you, Dr. Azam, sir. Thank
over
you.
to the
Yes.
Thank you, sir.
Thank you, sir. Thank you, Dr. Azam, sir. Once again, on behalf of the organizing committee,
if any questions are there, if there are any questions by the students, we have the masterclass group. I will be sharing my PDF. Most of the thing will be answered there without any problems, and we can take it forward. All right. Thank you, Gandhi, for your.
thank you, sir. Once again, on behalf of the organizing committee, ISA Mangalore and ISA Karnataka, I would like to convey my heartfelt gratitude to Dr. Azam, sir, for sharing his valuable time and knowledge with us. It was really a very thorough discussion with Dr. Azam, sir, guiding us through a minefield called ECG and making it look like a walk in the park. Hope the first day of this prestigious event was helpful to all, and the participants have made maximum use of this masterclass and will be eagerly waiting for the exciting classes ahead. Once again, sir, thank you for providing us with your valuable support in enriching our knowledge about ECG. Thank you, sir, and good night. Meet you tomorrow.
Thank you. And before I log in, I'd like to thank Sripat sir again, Sushma, for giving me an opportunity to be part of this. I have shared my number on the chat group, 9343001626, and particularly Anand Bengare sir. Thank you so much. I've been always in touch with you for this wonderful opportunity, and it's an honor to be associated with PG Excel. You always learn, and you also learn at the end of the day. Thank you so much, Anand sir. And my number is there on the chat group, and you can always WhatsApp me, and I will help you. Thank you so much once again. I can leave the group.
Yes, sir. Thank you, sir. Good night.
Thank you all.
1 second. Yeah, not me, man. Them only. Over, Allah.